Okay, one more thing before we start. The decision of the quiz master for each section will be final. And one more instruction: if you have any doubt in your answer or even the marks that are being awarded to you, please feel free to ask the examiner there and then, or share your views why you think your answer is correct and why do you disagree with the examiner, so that he can explain to you in detail why he has chosen certain thing as the right answer. Okay. Okay, Ankur sir, you can share your screen and we'll start with team 1.
Okay.
Best of luck to every candidate.
Are you able to see?
Yes, directly go to the full screen.
Okay. So, should we start?
Yes, sir. Yes, sir. Team 1, please unmute yourself.
Team 1, please unmute yourself. So, first quiz for you is look at the images. And first question is, what is your diagnosis?
Sinus trophy.
Loudly, please.
Sinus trophy syndrome.
Gaurang, are you able to hear?
No. I cannot hear you clearly. Please speak loudly.
Sinus trophy syndrome.
Your voice is cracking.
Your voice is not audible.
Sinus trophy syndrome, sir.
Sinus tarsi syndrome.
Yes,
Okay,
sir.
that is the diagnosis. I'll go to the next question. So this is wrong. Next question is, which are the two most common types of tarsal coalition?
Team 1 only to answer. Speak loudly.
Talocalcaneal and calcaneonavicular.
Talocalcaneal and
Calcaneonavicular coalition.
calcaneonavicular. Okay, you get marks for this question. Third question is, name the two signs which are seen in this.
T sign and anterotor nose sign.
Please speak loudly.
T sign and anterotor nose sign.
Anteater nose sign. And the other is?
T sign.
Sorry?
T sign, sir.
Can you
Ankur
please
sir,
repeat?
spell it out.
T sign.
T sign.
Yes, sir.
Okay, so you get half mark for this. And coalition can be of three types. If it is osseous, it is called synostosis. What is it called if it is cartilaginous and fibrous?
Answer fast.
It is cartilaginous chondrosis.
Okay. And fibrous?
Ankylosis. Ankylosis, sir.
Ankylosis. Okay, no, you get half for this also.
Half of 1, 1, 1, 2. Total 2 marks out of 4.
Total 2 marks.
And one more question, one more instruction for team 1. Please get a good voice. This thing, your voice is cracking. We will not allow you in the next round if we have to ask. Okay.
So you must have known the diagnosis by now. It is calcaneonavicular coalition. The two most common types are calcaneonavicular and talocalcaneal. So you get full mark for that. Two signs are, one is anteater, which is elongated anterior process of calcaneus, and the other is reverse anteater, which is elongated lateral navicular, which was seen in these two images. And osseous is synostosis, cartilaginous is synchondrosis, which you told correctly, and fibrous is called syndesmosis, right? So team 1 gets 2 marks.
Team 2.
Team 2, are you ready?
Yes, sir.
Yes, sir.
Okay. So this is your first question and the images. Identify the two main pathologies which are seen
अच्छा
in.
बोल के PVNS नहीं मतलब T1 पे है क्या PVNS तो रेफिगेशन से बोल
Pigmented villonodular synovitis.
नहीं abnormalities T2 hyperintensity collection disease T2 hyperintensity तो PVNS finding level diagnosis two main pathologies.
So these are the T1 weighted and fat set PD images.
Sir, we don't have time. We'll go to the next question.
And two main pathologies. You have told one PVNS, other
Joint erosion. Bone erosions.
Okay, next question is, which is the most common type of ankle impingement?
ankle impingement ये कौन सा कैनाल होता है टार्सल कैनाल होता है जो उसमें होता है कार्पल टनल टार्सल साइनस टार्सल
Ankle impingement. Should I go to third?
Yes, sir.
Which tendon is most commonly affected in the given impingement?
Flexor hallucis longus.
No.
कौन सा दिखा रहे हैं ये क्या
And last is, name these two angles.
यार छोड़
No? Should I go to the answer?
Sir, how many marks?
0.
Okay.
First is the two pathologies, they are extraarticular hindfoot impingement with there is synovitis. In fact, you can give 0.5 Gaurang actually because they said about synovitis, though they said PVNS.
Team 2.5 marks.
0.5, yeah. Most common type is anterolateral ankle impingement. The tendon which is affected in this extraarticular hindfoot impingement is posterior tibial tendon, which is commonly torn, and it is seen in this image is also as torn tendon. And the two angles are hindfoot valgus angle and the angle of Gisson.
Okay. Team 3. Team 3.
Team 3,
Yes, sir.
are you ready?
Yes,
Yes,
we
sir.
are ready.
Okay. These are your images. What is the complete diagnosis?
CAM.
Aneurysm
Aneurysmal bone cyst. No, so CAM type.
बोल
5 seconds.
Hip acetabular impingement syndrome. CAM type.
Next
No,
question.
that is not correct. Next is, what is the name of the deformity of femur?
এটা তো crook বল
shepherd
Shepard crook deformity.
Shepherd crook, that is correct. So now you do know the diagnosis, right? Name two syndromes which are associated with this condition.
MS
McQueen-Albright syndrome Trevor's
McCune Albright and
That is correct. So you get half marks for that. Last question is phlegmomachic, which is, you know, the mnemonic for osteolytic lesions. What is O and M stand for? F is fibrous dysplasia. What is O and what is M?
osteoderma lytic lesion तो lytic কি হবে
osteoid
M for malignancy malignant lytic lesion something or
It is very clear. So there is no O is
O is osteoid O is osteoid osteoma and
M for malignancy
second team point.
No.
Metastasis.
Oh, okay, I'll come to the answers. One is polyostotic fibrous dysplasia. You could see there are two lesions. One is in the sphenoid, in the ischium also, and the femur.
Sir, how many
Are
marks for
correct.
team 3? Sorry, sir. How many marks for team 3?
Yeah, I just come to that. So first answer you did not get. Second you get 1. In third you got half, and in fourth you did not get. It is O is osteoblastoma and M is multiple myeloma or metastasis. You can't tell
We
just
have said
malignancy,
metastasis.
right?
Sir, we have said metastasis.
No, you said malignancy, not
No,
metastasis.
metastasis we said at last.
Malignancy, I also heard. So, how much marks, sir?
So 1.5.
1.5 marks for team 3, Ankit bhai. Team 4, question 4.
Team 4.
Team-
Team 4, are you ready?
Yeah.
Okay. What is the diagnosis?
Ulnar collateral ligament injury, stenosis lesion.
No, that is not correct. What is the name of this condition? Which disease? This is finger MRI. I have written the sequences. No. Third is, what is the name of similar condition which occurs in head of metatarsal?
Friedberg and Eiling's. Friedberg's disease. Eiling's.
Friedberg. So that is correct.
Second.
And last is, what are the common etiologies for this condition? Fast.
The friction over wear and tear.
No, that is not correct. So you get 1 mark. The answers are,
Team
this is osteonecrosis
mark.
of head of metacarpal bone. It is called as Dietrich disease. Friedberg disease, you told correctly. And the common reasons are steroid use, lupus, trauma. Right? Okay. Team 5.
Sir.
So they get 1 mark.
Yes, sir. Yes, sir.
Team 5, are you ready?
Sir.
Okay. 18-year female with swelling of third toe since childhood, which is gradually increasing. What is the diagnosis? I'll also show MR. You can still give the diagnosis.
Macrodystrophy lipomatosis.
Correct.
Previous one.
Give 2 more names for this condition. You don't get this. Third is, what are the common associations?
Syndactyly. Syndactyly, sir, and polydactyly also.
Okay. Fourth is, which of the following is not true?
Progressive.
Fast.
D.
D. Okay, no, that is wrong. So the answers are macrodystrophia lipomatosa, you got it correctly. The other names are localized gigantism, macrodactyly or macrosomia, which you did not get. Syndactyly, polydactyly, you got it correct. And answer is A, because it is congenital, but it is
Not hereditary.
not hereditary, right?
Correct.
So team 5 gets 2 marks.
2 marks for team 5.
Team 6, are you ready?
Yes, sir.
Okay. 13-year boy with complaint of left hip pain with limping for a few months. Question is, what are the 3 closest differentials?
Septic arthritis. Septic arthritis.
Then
Perthes.
Perthes, you are saying the head of femur. Okay. Next. You have to tell 3.
Avascular necrosis. It is only Perthes.
I'll give you half point for this. Now, what is your diagnosis after looking at these images?
It's rotated. It's rotated somehow. It's rotated. This is called something.
No, these are the images at the level of neck of femur, axial images.
Time up for 2 questions.
Okay. Third is, what should be the next investigation of your choice?
Bone
What would you do next?
scan.
Bone?
Scan.
Bone scan. Easier would be CT. Now you know the diagnosis.
Slipped capital femoral, no?
No, it's not. Oh, osteoid osteoma.
Osteoid osteoma.
Which are the treatment options for this condition?
Radio frequency ablation.
Options. Other
Other one.
Ibuprofen, NSAIDs,
they are not definitive treatment. Treatment options.
radio frequency ablation.
That is correct.
Endovenous laser ablation.
So you get half mark for this also. Answer is osteoid differentials can be synovitis, which you told correctly. Right? Osteoid osteoma, that is the correct diagnosis. You should do a CT scan for confirmation, and RF ablation surgery, cryoablation, MR, FUS. Right? So team gets 1 mark.
Team 6, 1 mark.
Okay. Team 7,
Yes, sir.
are you ready?
Yes, sir.
Okay. 55-year male with swelling, no history of trauma, no history of any family member having similar complaint, and patient is on dialysis for renal failure. What are your 3 closest differentials? I have written the sequences.
Tumoral calcinosis,
Then
Heterotropic ossification in tertiary secondary hyperparathyroidism.
and one more.
4 seconds. Time up. Next question, please.
Okay. Now, what is your final diagnosis?
This is synovial osteochondromatosis.
No, that is not correct. That could have come in differential actually. What is the characteristic of tumoral calcinosis, which is the closest mimicker of this lesion? You already told tumoral calcinosis.
Yes, sir.
So what is the specific characteristic of that condition?
So, central calcification, progression of calcification from central to periphery.
I gave in the history that there is no family member, there is patient is on dialysis and no history of trauma. Last is name the crystals which are deposited in this condition.
Calcium hydroxyapatite crystal.
No, it's not calcium hydroxyapatite. For differentials, you were partly correct. It is tumoral calcinosis, synovial osteochondrosis, you did not say, but calcinosis of chronic renal failure. I gave history, patient is on dialysis with chronic renal failure. It is the primary characteristic of tumoral calcinosis. It is a familial disorder, which was not there in this patient. And the depositions are of calcium phosphate. So they get half mark for their first answer, which was partly correct.
Half mark for team 7.
Team 8, are you ready?
Yes, sir.
Okay. What is your diagnosis?
Ganglions. Gangliosis.
Next question is, what is the closest differential diagnosis? No?
Yes, sir.
What is the most common site for occurrence of the above lesion?
Dorsal aspect of wrist.
Your first answer
The
is not.
aspect of the wrist.
Your first 2 answers are not correct.
Index finger, sir.
What is the treatment of choice for this lesion?
Intralesional steroid.
No. The diagnosis is, it is fibroma of tendon sheath, This was histology proven. You can see the T2 weighted image. These are T2, which is not showing completely bright. It is in the along the tendon sheath. It is not in like the ganglion, which are away, which are adjacent to either bone or joint. This is completely, and this is in the finger. You hardly see ganglion at this location. And so the closest differential is tenosynovial giant cell tumor. The common location is finger, which, and the definitive treatment is surgery. So I can give you a half mark for your location. The third question, third answer. Rest of the things were not correct. So 0.5 marks for team 8.
Team 8, 0.5 marks.
Team 9, are you ready?
Yes, sir. Yes, sir.
Give complete diagnosis.
Infrapatellar bursitis, Hoffa's fat pad, there is inflammation, PDFS high signal.
Complete diagnosis. You said
Uh,
bursitis.
Trochlear
Correct.
dysplasia. Trochlear dysplasia is there. Patellar dislocation. Patella is dislocated. There is tear of lateral retinaculum is there, and patella is dislocated.
No, that is not correct. Second is name the fat pads which are seen at the anterior aspect of knee joint.
Hoffa's fat pad.
Then, okay. Third is name two ratios which are most commonly used for patella alta.
Insal-Salvati ratio
And
modified Insal-Salvati ratio.
no, that is same as Insal-Salvati, similar. One more I am looking for. Measure differently. Okay. Fourth is which of the measurement will change by changing the degree of knee flexion? Insal-Salvati, TTTG, both of them or none of them?
Both of them.
Both of them. That is correct. So you get, your first answer was wrong. The condition is Hoffa fat pad impingement. You said different. Answer 2 is Hoffa's fat pad. 1 you told correctly, so that you get half mark. Others are prefemoral fat pad, quadriceps fat pad. The ratios are Insal-Salvati or modified Insal-Salvati and Caton Deschamps. And answer 4 is both of them, which you said correctly. So you get 1.5 marks.
1.5 marks for team 9.
Sir, C option we told Insal-Salvati. 1 we told answer 3.
Yeah, you get half for that also. Sorry. So you get half and 1. So 2 marks for them.
Okay, 2 marks. Correction. 2 marks
Correction. 2 marks for them. Yes.
for team 9. Ankit by 2 marks for team 9. Next.
Team 10.
Okay.
Are you ready?
Yes.
Yes.
Okay. 43-year male with swelling at the dorsal aspect of both ankle. Name the affected tendons and your diagnosis.
Achilles tendon is affected, sir. Diagnosis.
Second question. What is the next investigation that you would do?
Ultrasound. Ultrasound.
No, I'm doing MRI of brain. Can you tell the diagnosis now?
Calcification. NCC.
No. Is this condition autosomal dominant or recessive? And is it a lipid or collagen storage disorder? If you don't get diagnosis, then it is difficult to answer.
Autosomal recessive, sir.
No.
Lipid storage disorder.
So that you get correct by chance. It is bilateral Achilles and posterior tibial tendon. So you get half mark for first. Next should be MRI brain. It is cerebrotendinous xanthomatosis. And your fourth was correct by chance. So you get 1.5 marks. Team 11.
Okay. Team 10, 1.5 marks. Now team 11.
Yes, sir.
Okay. What is the diagnosis?
Chondroblastoma.
Chondroblastoma in the head of humerus.
No, that is not correct. Second question, what is the stage of the lesion? Third, which is the bone which is most commonly affected by this lesion?
Humerus, sir?
No. Fourth is, which sign suggests presence of central calcification within the lesion?
Ring and arc, central calcification.
No.
Pass, sir.
Just look at the images. You are completed your time, but look at this. This is T1 weighted is bright lesion on T1 with central hypointensity. There is no edema to suggest chondroblastoma. Chondroblastoma should have significant edema.
Fat
The physis it is the fusion already done. So the answer is it is intraosseous lipoma. It is stage 3 because it has central cystic or necrotic area. Most common bone which is get involved is calcaneum, and that is the croquet sign.
Okay.
So you don't get any mark for this, unfortunately.
Marks for team 11, 0 marks.
0. Team 12.
Yes, sir.
Okay. What is the diagnosis? 25-year male.
GCT.
What is your diagnosis? Is it same or changed? In first you said GCTs. Quick.
Fluid level is dark enough.
I'll give it to you. You gave actually on the first only. This is a GCT. So it was meant to be diagnosed on first. How would you best describe this?
Soap bubble appearance.
This lesion, benign, malignant, locally aggressive?
Locally aggressive.
Locally aggressive. And histologically, which other bone lesion that exactly mimic this lesion? Histologically.
Histologically. Telangiectatic osteosarcoma.
No, that is wrong. So the lesion is GCT, which you told correctly. It is locally aggressive, and it is Brown's tumor, which exactly mimic this. So you get 3 marks out of 4.
Okay, 3 marks for team 12. And
Okay.
we are now at the end of the session. Thank you so much, Ankur sir.
Thank you.
The
And
top. Thank you, sir. And team 12 is the highest marks right now, 3 marks, followed by team 9, team 5, and team 1 with 2 marks each.
detecting it on X-ray was really good. I usually it comes as a chondroid lesion only when it is in hand. So fortunately, you got 2 marks out for that.
Great. So we move on to the next session. Okay. Chidam sir, can we have one heavy session of brain or head?
Yes.
Then we'll go for another light session then. Sir, what do you want to do, brain or head and neck?
First brain.
First brain. Brain and spine for everybody. We start from team 1.
Yeah, can you see that? No, can you see the slide?
Yes, sir. The first slide, that is the introductory slide.
Okay, thank you very much, Gaurav, for the nice, for the sessions. And I hope that everybody will be enjoyable. And I thanks for the the IRA for giving the opportunity. It is a great pleasure participating. Congratulations to all the team. Okay, all the best. Okay, only one thing I want to say. We have arranged randomized difficult level, same at the intensity of all the cases. We are not biased. So it might, maybe your luck, maybe we different sessions are okay. Okay, can I see that first one, team A?
Team 1, please identify yourself.
Yes, sir.
So can I move the slide first one? Can you check that is moving or not?
No, sir, not now. First question. Okay.
Okay. Question number, this is team A. Team 1, this is 31 years, ataxia and diplopia, dysarthria, altered facial sensation. The question is, what is the specific feature to say? And what is the diagnosis? Second question, and how to differentiate from others entity, and what is the confirmation? Just go through carefully and one by one I can answer.
Prepontine enhancement. So,
Are you hearing me?
Yes, sir.
Okay, please.
Prepontine patchy enhancements is seen lower.
Okay.
Diagnosis clippers.
Clippers, okay. What is features? Features. What do you say? Clippers. That's what specific features.
Inflammation enhancement in the prepontine and premedullary region.
Okay. How do you differentiate from other entities? What are the other DDs? There is no DD.
Harsax, sir. Autosomal recessive spastic ataxia.
Okay. No. That's no. What is the features entity? Other entity by imaging wise. Okay. Say confirmation. How do you confirm?
After giving a dose of steroid, will dissolve.
Okay, very nice. Okay. But team A get actually 2 points. 2 points, 2 marks.
2 marks out of 4. Team 1. Team 1, 2 out of 4.
Yes, exactly.
For brain session.
Okay, nice. Actually, we'll move on to the next one. So, okay, this is there's the clippers, correct? Okay, clippers actually that all of you know this lymphocytic chronic lymphocytic inflammation. As he said,
perivascular enhancement responsive to steroids.
Okay. So clippers, main thing, this is a punctate, patchy, linear contrast enhancement. That is a very characteristic. Cerebral peduncle and cerebral hemisphere involvement and cord is involvement. Little edemas. Okay. So DD is actually bile metastasis. There are neurobasis and the neurosarcoidosis, autoimmune disorder. This is autoimmune disorder. That's why we can differentiate. Okay. Good, actually. We'll move on to this. Thank you. Okay. Team A.
Team 2.
2 marks.
Yes.
Yes, 2 marks for team 1. Now team 2 will come. Team 2, please identify yourself.
Yes, sir.
Okay, this is a 55 years old headache. A patient have a male headache, and these are images. Just go through carefully.
में susceptibility नहीं है, peripheral diffusion restriction है. ये T1 gadolinium है, peripheral enhancement है, thick peripheral enhancement है, irregular सांस है, fungal तो नहीं लग रहा ना, नहीं है.
Okay.
Sir,
what do you think? What is the diagnosis?
Sir, T2 hyperintense lesion showing thick walled peripheral rim of enhancement with the diffusion restriction in periphery and not in the center. No susceptibility changes and marked surrounding edema. In the lesion is seen in the right half of cerebellum involving the right MCP.
So what is diagnosis? But you said about okay, we'll just finish. Okay, what is diagnosis?
Sir, keeping the age in mind, first would be a metastasis, differential.
Okay. No, diagnosis. Okay. Okay. Metastasis. Okay. That is a wrong answer. Okay. So okay, the question actually this is the one. What are the lesions that dark in T2? The dark in T2. What are the lesions dark in T2?
Calcified lesions.
Okay.
The lesions which have more of a hemorrhagic component and fungal abscesses can be dark on T2 due to.
Here, this is a dark in T2, and actually you said about is it hemorrhage will be GR will be dark, no? So how to differentiate for other entities? So you said about other things. So many things, no?
MR spectroscopy and MR perfusion.
No, with this available image here.
So the fungal abscesses will show susceptibility changes, whereas this lesion does not. Then, if it would be a mass, the enhancement would be irregular, nodular.
So I said about T2 dark. Okay, what are the entities? What are the name few conditions which are T2 dark?
Fibrous component and hemorrhages.
Here, so what lesion here? What is the lesion?
Pilocytic astrocytoma? No, 55 में नहीं होगा ना.
T2 dark, madam. T2 dark, peripheral enhancement. Okay. So you get only 1 mark so far. You're not given them diagnosis. Okay. So hypotenuse areas. Okay. You said about the fungal lesion. That is 1 more mark. Okay. Hypercellular lesion, high protein, and the hemoglobination product. But here hemoglobination product is not there because the GR image is not dark. So it is nothing but simple tuberculosis. Simple tuberculosis. Why simple tuberculosis? Why is tuberculosis dark?
Sir, the non-caseous component within the TP.
So, okay, 2.5 mark. Okay. The team 2 will get 2.5 marks. Gaurang?
Yes, sir. Yes, sir. 2.5 marks out of
2.5 marks. Okay, out of 4.
Out of 4 for team 2, 2.5 marks.
Exactly. Okay. We'll move on to the next case. Team 3.
Yes, sir.
Team 3 is a 2-year-old male. And this is the images. We already marked here. Just louder, please. I'll ask the questions next slide because it is so much, all the images we have provided.
So we have to describe the lesion.
You describe the lesion and what is the nature of the lesion.
So there is a large irregularly marginated lesion in the left cerebellum.
Okay.
And it is showing
only for right cerebellum. It is involved the right side also. It is only right side. Only right side or left side.
Left cerebellar hemisphere.
Sorry, left.
Okay.
Predominantly left, slightly involving the right hemisphere also.
Okay. Okay. Is there any way to characterize the lesion with the background of the morphological appearance and various sequences? Is it possible to see what type of lesions?
It is showing blooming on GRE sequences. So
whether congenital, traumatic, inflammatory, neoplastic, vascular, what kind of lesions?
Neoplastic.
Neoplastic. What? Malignant, primary, metastasis.
Primary.
What is the lesion?
What?
Medulloblastoma.
Medulloblastoma. Sorry? Sorry, you said?
Angle na to cerebellopontal angle lesion.
Cerebellopontal angle.
No, sir. No. We are just discussing that.
Whether intrinsic or extrinsic of the parenchyma.
Intrinsic.
Intrinsic. Okay. So the question is, what is the specific feature here? What is the diagnosis? How to differentiate from other entities? What is the entity did to what?
Sir, specific features.
What is specific feature? Specific feature is there, no?
So, diagnosis, what is the diagnosis?
First tell the specific feature so that make a diagnosis. So then will be differentiate from other conditions. Or the you have.
So this is posterior.
I'm not okay, posterior.
Fourth ventricle lesion and
cerebellar hemispheric lesion. Likely medulloblastoma. We will go for the medulloblastoma. And
answers and marks, sir.
Specific features.
Okay.
Bloom,
Okay. Is there any? How do you differentiate from medulloblastoma? Is it medulloblastomas? Okay.
Ependymoma we can differentiate if it is involving the ventricular extension.
If it is arising from upper roof or the fourth ventricle or the floor of the fourth ventricle, depending on that, we decide if it is ependymoma or not. Ependymoma, it is extended to the foramen of Magendie and foramen of Luska, but medulloblastoma generally do not, and medulloblastoma has drop metastasis.
Okay, no, I'm not asking this one. You tell me this particular case. What the entity, how the disorder due to what? Due to what actually this is a neoplastic process there. What is the most likely it is? Okay, it doesn't matter. Okay, I'll tell you that no, this is ATRT because it is a T1, and if you look at the areas, this is at young age. It's a 2 years old, and sorry, the 2 years old, and there is a dark areas, and there is a diffusion restriction, and there are multiple punctate hemoglobin degradation product on GR images, and enhancement, intensely enhancement, and there is a CBB increased. That means highly cellular tumor with multiple hemorrhage, and this is high-grade tumors. Okay, high-grade tumor, and this is how to differentiate from the benign lesions or medulloblastoma. Medulloblastoma will not have so much of hemorrhagic areas and infiltrating. Your lesions become more infiltrative. That's more important. And entity, what is the disorder? This disorder may be related to inactivation of the mutation. The SMART CB1. That's most likely. Okay, this is ATRT, atypical teratodermoid. The team 2 will get only
Team 3. Team 3.
Team 3 will get only half mark.
0.5 marks for team 3.
Exactly.
Okay, team 4, please identify yourself.
Okay, this is a team 4. Okay, the young woman with headache. This is appearing in a lesion, very characteristic appearance.
On axial contrast sections, T1 weighted image, you can see linear enhancing vessels in the periventricular region, and the corresponding one in the SWI shows blooming, linear blooming.
Okay, findings are correct. So what is the most likely diagnosis?
Periventricular developmental venous anomaly.
Developmental venous anomaly. What are the lesions can occur multiple linear vascular channels? So that is what there's no any specific sign here. And what is the reading and what is the technique which better seen in this particular case? Then what is the diagnosis? Each carries one mark.
Specific sign is that medusa head appearance.
Okay. Is the medusa head?
Medusa head or
okay. 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 It is what is the diagnosis? You said venous anomaly. What is the Sorry. What is the diagnosis? Said
venous developmental venous.
Developmental venous anomaly. Bilateral symmetrical. Okay. So for the okay. Now diagnosis venous anomaly is not there. It is a typical corkscrew appearance. Okay, it is occurs in bilateral symmetrical occurs in the multiple punctate corkscrew appearance occurs in sarcoidosis, neurosarcoidosis, very classical. But these are all will be you can get this linear channel. We'll get in other conditions like leptomeningeal tuberculosis and dual venous thrombosis and dual fistula, neurosarcoidosis. But neurosarcoidosis is very characteristic finding. Seljuber syndrome also can have their appearance. Okay, so team 4 get half mark.
Half mark for team 4, 0.5 marks.
Okay. Okay. Now we'll move on to the case number 5, team 5.
Team 5, start.
This is a 20 years old drug abuse, ARDS, intensive care unit. She is on ECMO. Okay. And this is the images were provided here. So there are some images. You identify this. This is 4 years before the MRI was done. This is the current MRI. So what do you think? What is the most likely diagnosis? Okay, based on this finding. Okay, what is the main finding represented and what are they and what is the DD?
So multiple microhemorrhages, watershed microhemorrhages, sir.
Microhemorrhage. Okay, microhemorrhage is due to what? Okay, microhemorrhage.
Septic embolism.
Septic embolism. Cocaine. But take the history. Okay, 4 years before normal. Okay, okay, right. This is not a multiple microhemorrhage is there, but a particular pattern. Okay.
Watershed.
It is not a
gray white matter. Gray white.
It is a gray white junction can occur in amyloid angiopathy, COVID-associated microbleed, fat embolism, and critical illness associated microbleed, and disseminated intravascular. These are multiple punctate bilateral symmetrical changes in the cortical not cortex, subcortical region. Very classical of critical illness associated microbleed. So team 5 will get half point.
0.5 marks for team 5.
Okay. So this because diffusely distributed microbleed and great white matter interface. That's why he gave. He gave that answer. So that's why he get the marks. Okay. Just get familiarity, the multiple area punctate areas in particularly critical illness in associated with the patient having that ECMO treatment. Okay, we'll move on to the next one. Case number 6. That is team 6.
So we didn't get time to look at the questions even, sir, and then the
sorry.
No, whatever it is final. We it is.
What do you want? What tell me? No, so no, doesn't matter. What do you want?
Where is the lesion they asked? Go down, middle, or up?
You said about one answer correctly. There's no multiple microhemorrhages, etc. Correct. That is okay. But answer only that give you the mark already. Okay.
Okay, sir. Next question, sir.
We'll go to this case number 6. Okay. This is 38 years old with neck pain, headache, And here, please tell me which quadrant there is abnormality. There is a 4 quadrant is there. Okay. A, B, C, D. Where is exactly abnormality?
B, C.
No, you tell me whether A or B or C or D.
C.
C. Okay. C is the wrong answer. This will be, it is a D. Answer D. Okay. There is a changes there. Something. Okay. That is something. Okay. What is the changes? You tell me now. So this is changes there. What changes? What is abnormality?
Anterior epidural something.
Okay. You tell me now. What is the, now it will be more focused on the particularly mid dorsal level. What abnormality? What is that?
Anterior epidural space, there is hyperintensity.
Okay. Correct.
Over multiple segments.
Involving multiple segments.
Correct.
It is.
It is finding correct. Okay. So what is most likely? What is it due to what? Difficult. Okay. Okay. Now, so what is most likely diagnosis based on that particular finding? Differential diagnosis. Is there anything particular say? 1, 2, 3, 4. Or what is diagnosis?
There is an anterior.
You already said, madam. You already said.
A membrane is there. Arachnoid membrane.
Correct. Arachnoid membrane. Is it arachnoid membrane?
Yes.
Yes, correct. So that is correct. Okay. So what is diagnosis? So what will get? Which are the conditions produce that area, linear single intensity areas, which is dark? With there is a you said about some abnormalities. So in which condition you will get, or what are the conditions you get this particular
trauma?
Arachnoid membranes can be post-infectious sequelae.
Infectious sequelae. Okay. Okay, it's not infectious sequelae. Diagnosis. Okay. Okay. Complications. Okay. Only you give diagnosis, only you can know the complications.
Complications, compression of the spinal cord.
Okay. It's not a compression. That is not wrong answer. So this is a, so you can get the linear membrane like you said about. Membrane is correct finding. Okay. But this is you can get an intradural arachnoid cyst or a CSF leak, a spinal CSF leak, a neuroenteric cyst, or a dorsal thoracic arachnoid web. These are all conditions can produce this symptom. Okay. This is spinal CSF leak is the correct answer. Okay. Which are, okay, why? Because this is a patient having spontaneous intraocular hypotension because the spur, osteopathic spur is impinge on the dura, it causing that there is a dural leak. It can occur in multiple conditions, osteopathic spur formation, or it can be related to a CSF venous fistula, producing there is a CSF leak into the subarachnoid space, or maybe adjacent to the epidural subarachnoid space, or maybe adjacent areas. So it is typically, it is going out of the subarachnoid space. Okay. So it is that's the reason CSF leak producing spontaneous intraocular hypotension. That is complication. So these people see case 6 will get now. There's no team get 6, maybe get off point.
0.5 marks for team 6.
Exactly.
Yes, sir. Next.
This is spontaneous intraocular hypotension. Okay. So we'll move on to the case number 7, team 7. So this is a patient having, so it is a middle-aged person having progressive weakness for the 4 limbs. So what is the most likely, what is the finding here? What is the most likely diagnosis? So you can see the images that this is a questions. What is the lesion in which compartment, first of all? So you can see that which compartment the lesion is there. The second one, what is the diagnosis? How to differentiate from this other entity? What is the characteristic features? If you want to go through, then I can, okay, I'll send one images backside. So this is what sequences? You can see the sequences.
Sir,
okay.
We can see multiple T2 hyperintensity involving the anterior column of the cervicodorsal vertebra, predominantly involving the C3 and D1.
So also diffuse T2 hyperintensity is involving the spinal cord.
Also, which is restricted.
Which compartment? Which compartment?
So cervicodorsal.
Sir.
No, not a cervicodorsal. So whether this is extradural, intradural, subdural, or intraparacable, or within intramedullary, which compartment the lesion is there?
So extradural.
Extradural. Okay, is it extradural? Okay. So what is abnormality?
So is it posterior longitudinal ligament thickening?
So where is posterior longitudinal ligament thickening? So which area is involvement? You tell me which area is involvement. You said about where is whether the anterior spinal column, anterior aspect or posterior?
Sorry, sir. Anterior spinal column is involved.
Anterior spinal column. Okay,
Yes,
it's the wrong answer. So it is actually look at the posterior compartment. This is look at that. This is the involvement of the dura. The dura is so much thickened. You can see the enhancement. You can see the dura is thickened and dark areas. Okay, the dark areas and representing these dark areas in T2 image, and there is enhancement on the meninges and the pachymeninges enhancement and the diffusion restriction not there. So the diagnosis, okay, what is diagnosis? It is nothing but actually IgG4, chronic inflammatory etiology of the dura. So it is a very dark signal intensity on the T2 image with diffuse enhancement of the meninges causing compression of the cord, which is responsible for the weakness. Okay, good. They'll get only off point.
0.5 marks for team 7.
7. Okay. Case number 8.
यार क्या आता है तो दिक्कत नहीं
Weakness for all the 4 limbs.
Weakness in all the 4 limbs.
Can you see the images?
Yes, sir.
Please describe the finding and see that. No, questions will be next slide. Okay. Okay. What is the? You tell me now. What is the finding? What is the important finding? What is the?
Sir, there is a intradural lesion which appears heterogeneously hyperintense on T2 weighted images and hypointense on T1 weighted images. It is causing spinal canal expansion and obliteration of the anterior and the posterior dural spaces and subsequent dilatation of the central canal and upstream syringohydromelia. And on post, can we see post contrast images?
Post contrast, very good. Okay, post contrast. Okay, this is post contrast.
Sir, on
post contrast. Okay.
Heterogeneous.
Sir, there is heterogeneous enhancement within the lesion, and there is hypo enhancement in the upper area.
Now the question is actually there's the questions now. So why there is a dilatation here, and what is the signal alteration within the expanding the cord? Why there is signal alteration? So
there is an intradural lesion, sir. Intramedullary lesion, sir.
What intramedullary lesions? What intramedullary lesions? Okay.
Ganglioglioma.
Gangliogliomas. So look at the areas that there is a clues there. No, just see the clue. Okay, doesn't matter. The key finding, what are the key finding? You are saying that no, there is a central canal dilatation or it is there. Okay, diagnosis you are missing. How to differentiate from other entities? Other entity means actually you said about this neoplastic process.
Yes, sir.
Neoplastic process. Okay. So then what is there any finding here?
The post-op.
Exactly. This is a post-operative. Then what is the cause of there is no central canal dilatation? Okay. So then, okay, doesn't matter. Now the question actually there's no here patient having that no.
So could it be bleed?
This is no, there's no bleed. This is a post-surgical arachnoiditis. Post-surgical arachnoiditis because after surgery there is arachnoid changes with there is a traction of the adhesions of the theca and along with the dura. So along the dura and the cord is expanding and there is a turbulence of the flow within the central canal. Okay, that's why causing there is a obstruction here with secondary syringohydromelias. Okay, the team get off point. Okay.
5 marks for team.
Okay, there's a central canal. You said about central canal dilation, but still that is not a full answer. Okay, that's why I give you 1 mark, half mark. Okay, so final answer this is post-surgical arachnoiditis, the typical focal arachnoiditis. There is no enhancement, only the dura is only the enhancement is there. Okay, okay. The case number 9, that is team 9. Team 9 is there?
Yes, sir.
Okay, this is evaluated for the the patient having evaluated for the involuntary movement with myoclonus. Is there any finding, abnormal finding or normal?
Sir, there is T1 hyperintense lesion involving medulla with surrounding T1 hypointense lesion is seen involving pontine region.
Okay. Pontine, which part of the pontine?
Right pontine. Right pontine region, sir. Middle cerebral peduncle near in close proximity to fourth ventricle.
Okay.
Fasciculus. Either both fasciculus. Involving the fasciculus of.
Okay, so what do you think? What do you think? You said that there is one finding, there is no medulla and there is something. Is there any finding here?
Yes, sir. Involving the posterior part of
periaqueductal canal also, sir. There is T1 hyperintensity.
What is
Subependymal regions.
So, what is this sequence? What is this sequence?
T1, sir.
This is which is T1? You tell me.
First one
is T1. Second one. Name the sequence.
Flare, sir. Second one is
flare. Okay. So what is the key finding? You said about only finding is there. You said about that there is a altered skin tendency in the medulla. What is the diagnosis? The reason for the entity and what is the pathophysiology and what is the significance?
Sir, T1 hyperintense lesion is there, so any bleed it could be there, and it is hypo and flare.
Okay.
Blood product can be there.
What is the diagnosis? Okay, so we'll get. So okay, I'll tell you. So time is up. Okay, this is a triangle of Bullen and Murray. This is a red nucleus and olive nucleus and contralateral dentate nucleus involvement. As we see, there is a hemorrhagic component. This is hemorrhagic component, and there is which is T1 bright and dark areas, and the olivary nucleus. Usually bilateral olivary involvement can occur. That is called hypertrophic olivary degeneration. But you can get in unilateral also. Okay. Typically caused because the red nucleus involvement and contralateral dentate nucleus with involvement of the typical Bullen-Muller triangle involvement, resulting in the olivocerebellar tract and then the dentate nucleus involvement, producing oculopalatal tremor. Okay, good. This is person get off point.
0.5 marks for team 9.
Yes, exactly. So, case number 10. That is team 10.
Yes.
This patient progressive weakness, both lower limb.
Sir, there is an heterogeneous lesion noted in the epidural space at the level of the D4 to D7 vertebral body.
Yes.
This causing compression of the spinal cord, and there is spinal cord edema noted. The lesion is hypointense on T1 and hyperintense on T2 and T2 weighted images, sir.
Yeah. So what do you think at this point of time?
Sir,
But this is, what is the sequence? This sequence. What is the sequence? What is the sequence? What is the sequence first?
T1FS, sir. T1FS.
First one is
T1, T2, and T1FS, sir.
T1FS. Okay.
So not
something is there, no?
So,
sir, there is the vertebral body shows. But उसमें T1 में hyper
but suppress नहीं
suppress नहीं हो रहा तो hemangioma.
So what is diagnosis?
Hemangioma, sir.
So this is a axial section T1 image. This is a okay. And
schwannoma.
Schwannomas. But the schwannoma will not have the irregular mark.
Epidural में है, so abscess.
So here post-gado fat suppression. And something.
Enhance कर रहा है.
Intense post-contrast enhancement is seen, sir.
So what is diagnosis?
Hemangioendothelioma.
Hemangioma, atypical hemangioma.
What is diagnosis? Come on.
Hemangio and
why do you say hemangioma?
Hemangio.
Why do you say hemangioma? Why do you say hemangioma?
So it's not suppressing on fat suppressing images, sir. It's bright on both
vertebral bodies.
So diagnosis. Okay. This is the key finding. What is diagnosis? You said what? How to differentiate from other areas? Something you said about so many other conditions. No, you said you
Sir,
said
it is
what is epidural? Other epidural lesion? What other epidural lesion have bright intense areas and contrast enhancement?
Meningioma could be one differential, sir.
So is it can it be meningiomas? What are the point for against meningiomas?
it is crossing the. It is going through the foramen.
Sir, in axial section, it is growing through the foramen.
Extraforaminal
But
extension.
T2, this T1 is bright, no? Area bright. Okay. This is a case where this is aggressive vertebral hemangioma. You are right for the wrong reason. Okay. This is bright areas, vertical striations, very characteristic feature. And you can get sometimes extra osseous component. Usually, extra osseous component not common, but aggressive vertebral hemangioma, I have that one. You will get 3 marks. Okay. Okay, 3 marks for this particular team. Okay. You get the diagnosis. Okay. Case number 11. Is it team 11?
Yes, sir.
See carefully, this is a 53 years old male, treated case of pituitary lesion, present with a tremor and uncontrolled jerk, right upper limb and left upper limb. That is, right upper limb is more than that of the left upper limb. Okay, 53 years old male. So what is the finding? What is the most likely diagnosis?
So there is in T2 images shows white matter hyperintensity in the subcortical white matter,
Okay.
and also along the external capsule region.
Okay.
T1 sagittal images shows post-op changes in the pituitary region, and there is some signal alteration in the pericallosal region.
Okay.
And higher sections of T2 shows hyperintensity in the periventricular white matter region and basal ganglia.
So,
Post contrast, there is no.
So what is the most likely diagnosis? Then what is diagnosis based on this finding you said? But I didn't ask for finding, but you asked for some findings there. But what is the most likely diagnosis?
Can be post radiotherapy changes or.
Post radiotherapy changes. Where do you say the post radiotherapy changes? Any particular feature?
Because the involvement of white matter, it is not diffuser. It is restricted to one areas, one window of the brain, sir.
Okay.
And also there is a previous history of pituitary lesion with the post-op.
So what is the pathological process during signal alteration? This one here.
Because of radiotherapy, there can be myelination disturbances.
Myelination will be
edema.
What do you call it? What do you call it? This one. So what information provided to the clinicians?
It is
tremor is there.
Tremor is there, yes, sir.
So what information to the clinicians? So that is more. We are working for towards patients, no, patients and the patient clinicians.
It is. It is. I think it is progressive and.
Okay. So you are. Okay, you are said about something. Okay, that's maybe partly correct. This is post-radiation leukoencephalopathy because of radiation and the level of pituitary level, and the typical leukoencephalopathy changes occurs. So you'll get 3 marks, but only communicate. There will be how to communicate to the clinicians. So it is nothing to worry, but just reassurance the patient and this one. It is a radiation changes only. Okay, so you'll get 3.5 mark. Okay. So case number 11, team 11 is get 3.5 marks. Okay.
Case number, sorry, team 11, 3.5 marks.
Exactly.
Okay.
Case number 12 or team 12, the male child, 12 years, short stature and super intelligent for his age. Okay. These are all some finding. So what is the finding? What is the most likely diagnosis?
In the cellular and supracellular region, there are multiple T2 hypointense and T1 hypointense flow voids. Calcifications But why super intelligent?
So is it fluoride?
Could be calcifications also.
Calcification. Okay. So with this finding, what do you think?
Could be craniopharyngioma.
Craniofaryngioма. But this is something contrast. We give contrast. What type of calcification get in craniofaryngioma? This is a pattern.
Coarse calcification.
See, this may not occur, no? Okay. So what is most likely diagnosis? What is the key finding to just suggest diagnosis? You said about this something, no, is it, you said about single wide area calcification, which is correct. Madam, you said about calcification or single wide areas? Both are different. So which key finding to suggest diagnosis? Then what is the pathogenesis of the lesion? What is the potential risk?
It could be flow voids, then hemorrhage could be a potential risk.
It look like hemorrhage. Okay, we'll move on to this one. So it is not actually like that. See, if we do CT examination, there are multiple rounded, like a multiple, like bodies. Okay, multiple body. This all will be calcified or like almost like a denture. Okay, like a denture. Okay, some other things look at dentures. Okay, denture, it is nothing but you will get teratoma, supracellular teratoma with the teeth formation. Okay, it is a ossified teratomas. Okay, you should not mistake as single wide areas calcification. It is more than that. Okay, it is almost like a bone. Okay, so teratoma is more common. Actually, this is the supracellular region, midline. Is it mature teratomas? Potential risk for malignant transformation. That is the key potential risk. Okay, they'll get off point. Okay, team 12 of off point. Okay,
0.5 marks for team 12.
so we'll whether we'll stop now or we'll go to the next.
We'll take a lighter session, CVS, then again come back to you.
Very good. Thank you. Thank you very much. Okay, all the best.
So before we go to CVS section, I would like to thank Chidam sir. Also, we have with us our goat, that is Murli sir, greatest of all time. He has started the Yuwa IRIA. Welcome, Murli sir. I think you are the part of the quiz. How are you feeling, sir?
Good, nice. Actually, I have not seen Murali. Okay.
Here.
Sir.
Hi. Sir, unfortunately, the video is not okay. Maybe
Yeah.
Okay, right. Thank you very much for the nice opportunity.
All the best to teams. Great show. Keep going. So I don't want to stop. Break the session. Go on.
Okay.
Go ahead.
Okay.
Just
after CVS, we'll come back again. Okay, thank you.
Okay, thank you, sir. We can stop screen sharing. Okay. I'll just update the marks of all teams. Team 1 is now at 4 marks total. Team 2, 3 marks. Team 3, 2 marks. Team 4, 1.5 marks. Team 5, 2.5 marks. Team 6, 1.5 marks. Team 7, 1 mark. Team 8, 1 mark. Team 9, 2.5 marks. Team 10, 4.5 marks highest. Team 11, 3.5 marks. Team 12, 3.5 marks. So the top teams are Team 10, 11, 12, 1, and then team 6 and 9. Okay, now let's go to the CVS section. Dr. B.M. Mahesha sir is with us.
Yes, I am there. This one.
Good evening, sir.
Yeah, good evening. Can I share my this one
Yes, sir,
PowerPoint?
you can share your PowerPoint screen, sir.
Yes.
Now we are doing CVS. Ankit bhai, we are doing CVS.
Is it fine?
Yeah.
Is it
Okay.
seen?
Yes, sir.
Yeah. Good evening, everyone. So I thank IRIA Yuwa team for giving me this opportunity and also to conduct this wonderful program for our young budding radiologist. And I welcome all the residents who are participated in this and come to this level. Congratulations and also good luck for the future sessions. For team 1, is it audible?
Yes, sir.
Team 1.
Okay, sir. What is the question, sir?
Images and think what exactly the finding is there. And this is the trophy sequence, cine sequence. So you have a systole as well as diastolic images.
Yes.
Next, I have given the perfusion images as well as delayed enhancement study. So with this, what is your impression, first impression?
Hypertrophic cardiomyopathy.
Very good. And what should be the minimal myocardial thickness to tell the diagnosis during
LV thickness.
diastole?
LV thickness more than 15 mm.
Very good. And the prognosis?
The prognosis is based on the obstruction, sir. We have to look for subtle hypertrophy and systolic anterior motion of the mitral leaflet. So if there is the obstruction, right, it is poor prognosis.
And then depending on the delayed enhancement pattern?
There is mid-myocardial patchy multifocal enhancement.
Okay. So in this, what is the prognosis?
Poor, sir.
Prognosis is bad because there is an involvement of the
septum.
Enhancement is there with almost involving the 60% of the myocardial thickness. So this will tell the patient is more prone for escape. So this team will get 1.5 marks.
1.5 marks out of 2.
Yes. Team 2. These are set of images. These are set of images. Identify the sequence where we will get this type of images. You can see the difference in signal intensity of the left ventricle as well as the myocardium, depending on the.
देख पहले ब्लड काला हुआ
Yeah.
मायोकार्डियम पहले सर inversion recovery sequence.
Once again, I will go to the next. This one. Identify the sequence.
Sir,
what it is called as?
So inversion recovery sequence.
Yeah, definitely it is a inversion recovery sequence.
Double inversion recovery sequence.
No.
Yeah.
It is
And
the
we
one
use
the particular term I am expecting in this.
Amyloidosis there is
No.
Sequence.
Now.
Sequence तो क्या होगा? Double in DIR.
No. The sequence is called as T1 stop sequence, Molly sequence, modified loop blocker inversion recovery sequence. It is not just a straightforward stir sequence. And where this sequence will be used in the cardiac MRI study.
Sir, when we suspect myocarditis, amyloidosis.
No. It will be used in myocarditis as well as amyloidosis also. This is a part of delayed enhancement study, where we need to differentiate the enhancing myocardium from non-enhancing myocardium. What is the correct value? Which one you are going to select in this? I have given 9 pictures of this, which is the most ideal image we need to select, or time, inversion time.
यहाँ पे myocardium 290 milliseconds, sir.
Yes, that will be the very right answer. Congratulations. Even you got 1.5 mark for this question.
1.5 marks for team 2.
Yes.
Even not worst. बस मुझे बहुत डर लग रहा था कि इसका नाम नहीं याद आता कोई बात नहीं मुल्ली मुल्ली कुछ बोला था
This is team 3, sir.
मुझे उम्मीद नहीं थी
Nice, sir.
वो दोनों यूज करते हैं
Mute yourself, team 2.
Yeah.
Team 3.
Yes, sir.
What is this image?
Cardiac CT image.
Cardiac MRI and MRI. Angiography image. Cardiac MRI angiography image.
No. Why you are telling cardiac MR?
CT.
Oh.
Is it possible cardiac MR in the present day to get this type of images?
This is cardiac CT.
Yes. Cardiac CT means coronary angiogram. Okay.
Yes, sir.
Next. Name the arteries diseased here and mention their course.
Right coronary artery.
Sure.
Right
There are
coronary
two arteries, picture A and picture B. I have given an arrow mark. Please identify the arteries. There are only 3 arteries are there, big arteries. They have a regular course.
Left anterior descending artery.
Yeah.
It
You
left.
tell about the A picture. So what is the artery?
That is
right coronary artery.
left anterior descending artery.
Fine.
And second one is
right coronary. Left. Coronary.
Right coronary artery.
Fine. So where they are coursing, the course of these arteries in the
Left
epic
courses between the left ventricle and right ventricle.
There is a term is there for that one.
Subpericardial.
That is, this is epicardial. These are all epicardial arteries. We are not talking about the endocardial. This one. What is the course of LAD in this picture?
Course.
Interventricular, anterior descending.
Yeah. Yes. Yes.
Anterior interventricular septum.
Yes. Anterior interventricular groove. And what about RCA? Where it runs?
Right heart border, right.
No. You just now told no. For LAD is running in the anterior interventricular groove, whereas right coronary artery runs in the
coronary.
Right AV groove. That's all.
And AV groove, huh? AV
yeah, and the left circumflex artery, it runs in the AV groove. This will run in the interventricular groove, whereas circumflex will run in the AV groove, atrioventricular groove. So you will get again 1.5 marks, your team.
1.5.
Yeah.
For team 3.
For team 3, 1.5 marks.
Yes, sir. Team 4.
Team 4. Ready?
Yes, sir.
Are you able to see the image?
Yes, sir. Yes, sir.
Yeah. Name and identify the diseased artery. Loudly. What is the investigation? Conventional angiogram. LAO view. We are showing the 2 arteries, which is diseased here. It is very simple. There are only 2 arteries in this view. Major arteries. Can I go for next slide? So you can come back. These are MR.
LAD.
Yeah, LAD is correct. What you are seeing on cardiac MR images?
We're seeing some cardiac delayed enhancement in the LAD territory.
One second. This is the stress perfusion image. This is the delayed enhancement study. So what you are seeing on stress perfusion?
Stress perfusion looks normal. There is no
perfusion looks normal.
Yes. No correspondingly, we don't see any defect in that region.
No, LAD artery you are telling there is a diseased LAD artery. Where is the LAD territory in this short axis?
Okay, that is not enhancing. Then this is like showing the delayed enhancement.
So there is a less perfusion is there. Whenever you see a darkness, that means under perfusion is there. That means the contrast is not flowing. There is a perfusion defect. What about in this delayed enhancement study?
Facing late gadolinium enhancement.
That means what?
It is an infarcted tissue.
Huh? So there is a stenotic LAD with infarction of the LAD territory. So they will get 2 marks.
2 out of 2?
2 out of 2.
2 out of 2 for team 4.
Yes. So team 5. Five-year child. Team 5.
Yes, sir.
Yeah. There are CT images, contrast CT study, almost done 20 years back, this study.
We're not visualizing the rising RC is posterior mediastinum. Mediastinum mass भी दिख रही है.
Yes.
And right atrium, likely atrium exoma. Atrium, atrium.
Okay, the possible you are thinking in terms of there is a mass lesion in the which
Right.
chamber of the heart?
Left atrium.
Left atrium.
Left
Okay,
atrium.
what will be your diagnosis by looking at these images?
Atrium exoma. Rhabdomyosarcoma, atrial myxoma. These two.
5 years, sir. 5 years. Rhabdomyosarcoma, all these things, they will come from the myocardial wall. Myxoma from the leaflets. Okay, I will move to next slide. Now, have you got some idea?
Tuberous sclerosis का कुछ.
Yes. So what is your final diagnosis now?
Angiosarcoma, tuberous sclerosis. Okay. Angiosarcoma.
Is
This
that?
there's a not only the left ventricle.
Yes. So it's the
the
tuberous
foramen of
sclerosis
Pulrokisan,
with
central
cardiac rhabdomyoma.
rhabdomyoma.
Yeah. So
Tuberous
because sarcoma you told, so that's why half mark is cut for you. So you are getting 1.5 marks, 1.5 marks.
1.5 marks for team 5.
Yes. So these are cardiac images. You have a stir images as well as delayed enhancement studies. For team 6,
There is subepicardial enhancement.
wonderful. Yes. So what is your diagnosis?
Subepicardial, what all is it? Sarcoidosis. And then amyloidosis will be mitral, no?
Subepicardial enhancement. Patient will have a dysfunction, cardiac dysfunction,
MI.
tachycardia.
Not MI. Tachycardia, subendocardial enhancement.
Subepicardial.
Oh, sorry, subepicardial enhancement.
So this is the subendocardial.
Myocarditis.
Yes. It's a case of myocarditis. You are getting 2 marks. Okay.
2 out of team 6.
2 marks.
2
Yes.
for team 6.
So team 7. Team 7.
Yes, sir.
Yes. What are these images? And what is the procedure? What is the finding? Abnormal finding.
Bypass grafting, Limalad.
So this is a cardiac
So cardiac CT
Cardiac
angiography.
CT,
angiogram.
3D volume reconstructed images. And
BRT images. Okay.
the
What is
below-
the procedure done for this patient?
So Limalad bypass graft.
Surgical procedure.
Limalad bypass grafting.
Yes. So this is a CABG, coronary artery bypass. This one. Arterial sequential grafts. So there is a sequential grafts to LAD as well as LCX.
Yes, sir.
And also the graft has been kept for the PLV.
PLV, sir.
PLV. But in this picture, the PLV is
Attenuated.
PLV is occluded. We are not able to
Yes, sir.
see
Occluded.
pacified.
Occluded.
Huh?
Yes, sir.
Huh? So the important finding of this patient is the PLV is occluded. The graft has been, because indirectly we can see the clips are there. So that indirectly it will tell. So there is a PLV occlusion.
Yes, sir.
So you are getting 1.5 marks.
1.5 marks for team 7.
Yes.
Team 8.
This for team 8. Again, this will be a straightforward case. These are the cardiac CT.
Sir, these are the pulmonary angiogram cardiac CT.
Yes.
And we can see a sir atrial septal defect at the level of SVC, superior type of sinus venosus type of ASD. And so we can see a pulmonary vein draining into the RA. That is a partial anomalous venous connection into the SVC. So supracardiac type of EAP.
Yes, yes. Your answer is correct. Congratulations. You are getting 2 marks. Here there is a double SVC are there, left as well as the right side SVC, and pulmonary vein is draining to the right SVC, and also there is a defect between the two atria. This will tell IASD with PAPVC.
2 marks for team 8. 2 marks for team 8.
So again, one theoretical slide. New Lake-Luz CMR criteria for myocarditis. There should be 3 criteria on T1 and 2 criteria on T2.
Team 9.
So I wanted you to fill the blanks. What others should be their criteria? You have a late gadolinium enhancement.
Late gadolinium
T1 mapping values. What will be the third one?
Increased your mapping values and involvement. Thinning of myocardial wall is there, sir. Thinning of myocardial.
T1 criteria. Myocarditis, you don't get thinning of myocardial wall. Previously, we used to see edema, hyperemia, and enhancement.
Yes.
Now, according to new Lake-Luz criteria, for proper diagnosis of myocarditis, you need to have a T1 as well as T2 criteria. I have mentioned 2 criteria out of 3. I wanted you to tell third criteria. What should be? Okay, T2 criteria, one I have shown, increased T2 mapping values, and one more, that is a conventional T2 criteria that shows brightness.
Increased hyperintensity, T2 hyper.
On what sequence? That is more important. Because regular T2 sequences, we don't appreciate hyperintensity on myocardium. It is the stir sequence.
Stir sequence.
Okay.
Yes.
In this, you need to have a ECV, extracellular volume. So that will be the criteria. Increased ECV values will be there.
Increased ECV.
Okay.
Yes, sir.
0 marks, sir?
They are getting 0.5 marks.
0.5 marks.
Yeah, half mark.
Half marks for team 9.
Yeah. Team 10.
Vasculitis.
What type of vasculitis?
Sir,
The circumferential
thickening of the great vessels,
great
that is
vessels.
the left subclavian and left common carotid arteries, sir. And also क्या है? Abdominal aorta.
So, aortitis, Takayasu.
Takayasu, sir.
Yeah, aortoarthritis.
हाँ.
Give them 2 marks.
Okay, 2 marks.
Yeah.
Of 2.
Team 11.
Yes, sir. Coronary angio images and stress perfusion images have been provided.
Yes.
And in stress perfusion, we could see hypointensity along the septum, sir, predominantly along the septum. And the inferior wall of right ventricle, some hypointensity is there.
Anything
And
on the coronary angio?
in angio images, in along LAD, there could be, I think this is dissection, sir, because dissector.
No, if there is any finding like narrowing or
In
occlusion.
LAD, there is luminal irregularity and
It is not significantly narrowed. Okay,
narrowed.
at least
Yes,
we can tell like that. Huh? And then stress perfusion, there is a defect.
reversible defect. Yes.
Yes. No, there is a defect because
Defect.
still you have to see delayed
Delayed
enhancement.
enhancement.
You can tell this. Okay. Now I am giving the early gadolinium enhancement and the
Sir.
late gadolinium enhancement. So what is
So-
your diagnosis? Straightforward diagnosis. Only MRI can give spot diagnosis for this disease.
Sir, in both early and delayed, there is transmural enhancement of the
Okay, fine.
septum, sir.
Septum. But
Suggesting
in between you are seeing something dark, no? What is that?
could be
Transmural
clot.
means it should be entire this one, but you are not seeing something is not enhancing. It is looking very dark.
Yeah.
It is happening in even in perfusion as well as early gadolinium enhancement as well as late gadolinium enhancement.
Could be some deposition or
Usually it will be seen in the acute MI patients. And patients will have a
hemorrhage.
normal coronary arteries, but infarction will be there. What it is called, and these patients are more prone for arrhythmias. So this is a case of microvascular obstruction, no reflow zone. Only the smaller arteries will be occluded, and whatever the means degradation of blood products, they don't allow the contrast to streak into the inside. So this is called no reflow zone or microvascular obstruction.
Okay, sir.
So they will be getting 0.5 marks because they have told about the stress perfusion, not answered other things. Huh? Okay. Team 12.
Yes, sir.
It is a theoretical question. Adenosine. It is a potent vasodilator and it is used in the stress cardiac MRI study. Now I wanted you to tell what is its half-life and what is the dose used for the cardiac MR study, stress MR study. Team 12.
10 minutes. Very short half like
2
seconds.
minutes.
So 120 seconds half life.
No, just guess properly.
Like 2. It's less than a minute now. It's less than 6.
Half-life of adenosine.
It's very short, like less than 30 seconds. Less 60. I don't know what exactly.
And the dose used for stress MR study. Treatment, there might be a different doses. So whenever the patient has arrhythmia on the OT table, they will just inject vials and all. But what is the dose for the cardiac MRI study? Minimum dose. So half-life of adenosine is,
For like 2 to 3 minutes.
it is less than 10 seconds. So that is making adenosine is the best vasodilator to be used in the stress MR study. What is the dose you need to use?
The
Then
point
only you will
five,
get the effect. Yeah.
0.5, 0.4 to 5
What? Oh, 0.4 gram or milligrams? Or,
milligrams.
no, your answer is wrong. Guess. It is 140 micrograms per kg per minute. You have to calculate and give to the patient as infusion. So that will come around 24 to 30 milligrams for a patient with 60 to 80 kg. That should be injected in a span of 3 to 4 minutes. Then only you will get a proper vasodilatation. Okay, thank you. This last team,
Zero marks.
because they just some 30 seconds initially, so we
Okay.
can give 0.5 marks.
0.5
Okay.
marks for team 12.
So,
Okay.
thank you, one and all the participants. I think they answered very well. Congratulations and all the best for the future sessions. Thank you, Gaurav, and thank you, your team.
Thank you so much, sir. Thank you, sir. I would like to now update the scores. I would also like to repeat, team 12 gets 0.5 marks. So now the total score, highest team is team 10, that is 6.5 marks. The second highest is team 1, 5.5 marks. Then 4 marks is team 2, team 5, 4 marks, and team 11, 4 marks. Followed by 3.5 marks of team 3, team 4, team 6, team 6. Then 3 marks each of team 8 and 9. On the lower score is team 7, that is 2.5 marks. I hope I have declared all the marks. Sir, you can just drop the screen sharing. Mahesha, sir, you can stop.
Yeah, doing it.
Now we will again go to the Chidam sir session, that is head and neck. 2-minute long session, 4 questions, 4 marks. Welcome again, Chidam sir.
Okay, can you see that slide?
Yes, sir, the car slide.
Right, okay. Is moving?
No, you have to go full screen probably.
Oh, it's already okay, I'll do everything. Can you see? Can you see?
Yes, sir. Yes, yes, sir.
Okay, just see that moving.
Yes, sir. Now it's a blank slide, sir.
Right, very good. Okay, good evening again. It is wish you all the best. We'll for the next session also head and neck imaging. Okay, can you see the slide?
Yes, sir.
Okay, right. Now team A. Okay, that is case number 1. Okay, 42 years old female. There are some images. Okay, for head and neck. Okay, so what is the diagnosis? What is the cause? How do you say it? Something is finding is there. What to say that? No, what are they finding? What is it? Just go through all the images, see all the sequence wise, and there are 4 questions. Each question carries 1 mark. What is the diagnosis? You can give the full diagnosis. Then what is the cause? There is within that one, and why do you say any specific finding? Then what is that? Okay, then what is the okay?
Pontine hypoplasia.
Sorry, pontine hypoplasia.
Yes, sir.
Okay, is the pontine hypoplasia? Okay, this is the wrong answer. No, we have cleared this. No, head and neck image. Okay, doesn't matter. This is the wrong answer. What is the cause for what is the cause here? Can you see
Sir,
the what is the yes
sir,
whole?
sigma, sir, mastocytitis with the sigma sinus thrombosis.
Mastocytitis with sigmoid sinus thrombosis. Okay, is there any finding other?
With the pachymeningeal enhancement meningitis and the subdural hygroma, empyema.
Empyema collection. Correctly tell me. So then, what is diagnosis? What is the diagnosis? Complete diagnosis.
Left side mastocytitis with the sigmoid sinus thrombosis.
Mastocytitis. Okay, there's something wrong.
With meningitis.
Okay, there is a. Okay, you are partly correct. Okay, now you go through that images. Okay, go through the images. Something is there? No, something that you are. What do you think? What is something in the second image? That is like, what is the sequences? What is the sequence? What is the sequence? Arrow. Can you see the images? Can you see the images?
Peripheral diffusion restriction is seen, sir.
So what is diagnosis? You are not given the diagnosis, full diagnosis. So mark will be, will be shared. Go through the again. And this is cause and what is say specific diagnosis and what the complications. Okay, doesn't matter. So this is lateral sinus thrombosis, complication of the autogenic infection can still present as a serious threat. Okay. What is the cause? You can see the cause. You can see that no cholesteatoma. There is a cholesteatoma which appears peripherally bright, no enhancement, no enhancement. And there is a dark. So cholesteatoma with there is associated cholesteatomas. Okay, middle ear infection, not mastocytitis. Okay, mastocytitis also is there, but the extension. And the lateral sinus thrombosis with the associated phlebitis, and there is a subdural empyema, as you said. So you will get, you said about empyema, you said, and mastocytitis you said, but you failed to diagnose that this one. So you'll get 2 marks out of 4. So a left cholesteatoma with epidural empyema, okay, dural sinus thrombophlebitis. So you will get 2 marks, okay, 2 marks. Okay.
What is the 2 marks for team 1?
Yeah. Okay, for the team 1. Now we'll go to the case number 2, team 2. Okay, this is a child 10 years, swelling in the right cheek. Can you see the images, madam?
Yes, sir.
Yes, sir.
Okay, case number 2, child 10 years old, swelling the cheek past 1 year. So what is
Expansolated lesion in the bone and the right maxillary sinus was eroded. Septum तक जा रहा है और inferior wall तक जा रहा है, उसको भी खराब किया हुआ है.
So I can't hear you very clearly. Okay. So what is the finding? Just give the brief finding. And
Nasal sinus involvement बोल दिया. Sir, heterogeneously hypodense soft tissue,
you can see
which is seen primarily in the right maxillary region, reaching up till the nasal septum, inferior floor of the orbit, and causing the adjacent bone destruction. Arrow indicates the posterior wall of maxilla, which is thinned out.
Okay.
And the diagnosis SFT?
What the arrow indicates. So you said about finding. So you said about arrow. What is the arrow indicates? So the finding, the mark depends on the diagnosis. Okay. How they elicit the diagnosis, that is more important. Okay. Your finding, okay, may be correct. And you have to be appropriately application. What is the diagnosis?
SFT, sir. Solitary fibrous tumor.
Solitary fibrous tumor. Okay, solitary fibrous tumor will have this type of
Rhabdomyosarcoma, sir. 10-year child.
Okay. So this is a 10 years old child. Okay. So important. Okay, this is what type of appearance exactly? And how do you confirm quickly?
GCT of the maxillary bone.
10 years.
So bubbly, soapy, bubbly sort of appearance.
Okay.
GCT of the
It will
maximum.
not occur this age group, madam. 10 years, no.
30 years.
Doesn't matter, leave it. This is expanded lesion and thin eggshell type of rim of calcification or that bone buttressing. Okay. So there's a 10 years old. Expanded multiple loculations, septations, and there is no. Okay. That of course, this is ABC, anusomal bone cyst. Okay. CCT will not occur this age group. Okay. Expanding lesions. So you'll get 2.5 marks. Okay. The team 2 will get 2.5 marks. Okay.
2.5 marks for team 2.
How do you confirm?
MRI.
MRI. What you will see?
Fluid, blood fluid levels or fluid levels, sir.
You will get 1 more mark. Okay. 3.5 marks, sir.
3.5 marks out of 4.
Very nice. Okay. Case number 3, team 3. So 45 years old, severe frontal headache.
Yes, sir.
So what do you see that here?
Glioma, nasal glioma, I think.
Okay, what type of pathological? First of all, give the finding. Then instead of giving nasal glioma, you say that what is actually important. Okay, go through carefully and give the finding. There are some more findings there. Okay, there is a contrast. Patient having that important thing. There is a headache and nasal discharge. Okay, what is the cause for the nasal discharge? That is more important. Okay.
Cribriform plate is resorbed. There is it cannot be seen.
Okay. So okay, and there is where is the pathological process? Which bone? Which is
Frontal bone.
frontal bone? How the appearance? Is there any particular feature?
Lobulated appearance. Involving ethmoids, nasal cavity
It is ethmoid. It's not ethmoid. It's ethmoid.
It is not ethmoid.
Okay. And there are some things there, no? That finding you are missing. Okay, it doesn't matter. Leave it. So, what is the expanding lesion? What is the diagnosis? What is the arrow indicates? There are some arrow indicators, no?
CSF rhinorrhea.
Yes, totally wrong. So, this is okay. So, expanding lesion and there is how do you proceed? So, expanding lesion. We see the expanding lesion in the T1 and T2 dark. So, and there is something, multiple bubbles like, and enhancing, peripheral enhancing lesion, which is causing the nasal discharge. Okay. So, what is the proceed? Proceed by the MR. Okay. Proceed further approach by MR. Okay. From MR to CT. CT, what is the diagnosis? Okay.
Frontal bone osteoma.
Osteoma. We are not mentioning about the frontal sinus osteomas. Okay. CT, you are failed to demonstrate. Okay. MRI. CT will give the diagnosis. Okay. So, intrasinus osteoma with there is a secondary feature of there is a nasal obstruction, particularly orbital proptosis, and there is why this is actually the abscess formation. You fail to demonstrate the abscess formation because it's a periorbital abscess in the extracorneal space. Okay, because the intrasinus expanding with obliteration of the osteometal complex resulting in there is some retained secretion and this one. Okay, complete diagnosis intrasinus osteoma with stasis. Okay, you'll get because you said about after that. So 2.5 marks, 2.5 marks.
2.5 marks out of 4 for team 3.
Exactly. So the case number 4, there is team 4. The pain in the right orbit started with the posterior fossa surgery.
First, in the right eye, you can see there's a defect in the lateral aspect of the eyeball, and there is some hypointensity that is noted in the vitreous chamber. The lens is also not seen. Okay. Then in the posterior fossa, okay, that would be post-operative changes.
Which one post-operative changes? That is posterior fossa surgery was done. Okay. Okay, now we'll move on to the questions. What do you think here? And some more images. And this is images and some more images. Okay. See all the sequences, all the techniques important. Okay. That give the value for the value added for the your diagnosis. So what is the sequence? What is the sequence? What is the sequence? So what is the finding? Okay, you said about there is a defect, you said.
The right optic nerve appears more thickened and chosen.
So what do you think? What do you think? Okay, what do you think? What is the key finding here? Important thing. What the arrow indicates? And you already said, what is diagnosis? What is prognostic indicator here? It's important, no? You have to say the key lesions.
So could be right optic neuritis.
Optic neuritis, how do you get optic neuritis? Okay, optic neuritis, how do you explain that? No, the defect here. Okay, doesn't matter. Okay, now we'll see that. No, they say what is it? This is a diffusion wetted image. There is a nerve activity because single alteration is that which is appears dark, which is appears dark in the and there is a multifocal of hemoglobin radiation product with there is a defect, global defect, or maybe you mentioned about the retinal or maybe chorioretinal layer defect and globe rupture. What is cause of global rupture? This is acute ischemic orbital compartment syndrome in the right orbit, ophthalmitis with the optic neuritis and globe rupture. Globe rupture and optic neuritis said. Important thing, no, you mentioned about the two things because it is a arrival diagnosis. It is a compartment syndrome. It is a emergency situations. Okay, the prognostically value because it is you cannot see the patient actually there. So because this is related to a prone surgery because the patient in prone surgery resulting in there is an increase of intraocular pressure with reduction in the perfusion pressure of the orbit resulting in decreased ocular perfusion resulting in ischemia and the chorioretinal layer and globe rupture. This is the necrotizing endophthalmitis, okay, with global rupture. Okay, you will get. So you said about two things. One is globe rupture. You said about optic neuritis. Said about. So you'll get two finding. You will get 1 mark. Okay, but fail to diagnose this is very critical and very important thing. Okay, you will get 1 mark.
1 mark out of 4.
The most important thing, please understand that the tending, the angle is more important. If there is angle, usually will be around 130 degree. If anything less than 120 degree, it is emergency. Okay. Okay, case number 5. So we'll move on to the next one. 67 years old female, team 5.
Sir.
Okay, 60. Can you see the images?
Yes. There is a.
Yes, that's it. 67 years old female with significant right proptosis and headache. There are images. You see all the images. So what do you think? What do you say?
So there is a well-defined lesion noted in the right optic nerve, sir, causing its expansion, which is appearing hyper intense on T2 weighted images and and shows a peripheral rim of hyperintensity on the T and shows enhancement on post-contrast images and likely sir the optic glioma nerve sheath tumor, sir, optic nerve sheath tumor. Glioma it is an intrasubstance and bubbling appearance. So can be optic nerve glioma.
67 years optic glioma. See carefully.
Can be meningioma, sir, optic sheath.
Meningiomas. So where is the meningioma?
Enhancement, but there is no enhancement.
How to get enhancement? Enhancement, how they?
No enhancement is there.
See, what is the type of enhancement? Okay.
It's a peripheral enhancing.
You can see some more images and areas. So you can see that which compartment is arising from. Okay, that's more important. That is my questions. Which compartment, which key finding, what is the compartment is arising from?
It's an intraconal, sir.
intraconal. Okay, this you can see the optic nerve seen separately.
No, optic nerve. Yes, sir. From the optic nerve, it is rising.
Don't say that no optic nerve. The optic nerve pushed, but
Yeah,
here
optic nerve is pushed towards sir, lower part of the medial and lower, sir.
you set up, but initially you set up
Infromedial, infromedial, sir.
So you see that what is the diagnosis? What is the you are finding?
Dark on T2. Dark on T2.
And dark on T2, but it is not dark on T2 here. What is the difference between this one and this one?
Right.
If you take this one, you will get the answer. Say T2, what is this? What is the sequence?
FS. ये SOV का कुछ
What is the sequence? What is the sequence? That is more important. If you say the diagnosis over. So that's why dark on such sequences you are missing. Okay. How the diffusion?
T2FS, sir. T2FS.
So this is not FS. No, FS is there. Okay. Okay, FS alone. Okay, is it also FS? No.
Correct, sir.
So that is not, this is the here also suppressed. Okay. Everything suppressed. It's not suppressed. Here, this will be dark. Okay.
So
the key
T2, sir, is it T2 top? No.
T2.
T2.
So how do you proceed?
We can go for MR angio.
MR angiography. Why MR angiography? You have to justify.
Sir,
wrong diagnosis and the wrong thing. Okay. This is nothing but it is a dark because a dark in the GR images. Okay. Look at the area. GR image is dark. And this is a T2 image bright. So which one is dark? This is nothing but a thrombus or the venous malformation. Okay. There is a venous malformation with thrombus and this one. So how do you proceed? Important thing you can do a thrombosis and proptosis, optic nerve compression always need decompression, surgical management. Okay. So you'll get off point. Okay.
0.5 marks for team 5.
5. Okay, 0.5. Okay. We will move on to the case number 6. So what is the diagnosis? What is the finding? What is the diagnosis?
Inferior orbital wall defect is there, and there is a protrusion of the contents into the maxillary sinus, blowout fracture with the teardrop.
Okay, a simple, very simple case. Okay, but the question is not as simple. Okay, question is actually what are the key findings you said? Then what could be the presentation? What is the diagnosis, and what two important complications in this case? That is important.
Okay, presentation patient we might have enophthalmos.
Enophthalmos. Presentation will not be enophthalmos.
Sensation, loss of sensation of the cheek.
Why?
Infraorbital nerve will get injured.
Okay. Then what is the diagnosis? Blowout fracture.
Blowout fracture.
What are the two important complications?
Infraorbital nerve injury. Vessel also.
Most important complication. Okay, doesn't matter.
Optic nerve compression.
Optic nerve will not compress, but optic nerve will be separate. Here, important thing you have to look for the inferior rectus muscle because entrapment of the or impingement, and the most important patient present with the diplopia, and as you said, it can be related to optic infraorbital nerve entrapment. There is the trigeminal neuralgia. There's V2 division, maybe neuropathy or neuralgias. And most importantly, this is oculocardiac reflex. That is most important. Oculocardiac reflex. That's why I'm putting that one. Okay, I put the mark for 2 marks for that one. The blowout fracture will be very easy. That's why I put actually. So you will get area of 2 marks. Okay, 2 mark actually. This oculocardiac reflex is most important, most vulnerable, and more prognostic value. Okay, thank you. You will get 2 marks.
How many marks, sir?
2.5. That 2.5 marks.
0.5 marks for team 6.
Okay. So white blowout fracture. Okay, doesn't matter. This okay. Case number 7. So what do you think? What is the abnormal finding? This is what is sequences. They already written T2, gadolinium T1, and this one.
We can see a T2 hyperintense linear structure, which is showing post-contrast enhancement.
What is this one here? So diagnosis, finding diagnosis. and what is actually what is the clue for diagnosis? What is the presentations? Okay, I'll show more some more.
Sir, you can see the enhancement of cysternal segment of.
So what is the diagnosis? Cysternal segment. So I will not. Cysternal segment does not matter. Not why. What is the significant? What is this one? So you tell me what is the key finding? Number one, what could be the presentation? What is diagnosis? What is the arrow point in the coronal T1-FS? Everything together, no constellation of finding, you will get the answer.
Trochlear nerve.
Muscle.
So it's superior oblique muscle involvement.
So superior oblique muscle, why should have involvement here? What involvement?
Due to third nerve.
Sorry, third nerve. Third nerve is the course. So okay. So the wrong answer. Okay, you get superior oblique muscle involvement. You said that is a correct. Okay. So it is a superior oblique muscle, the trochlear nerve palsy because of that. It is a,
Sir, we told trochlear nerve.
Trochlear nerve. Trochlear nerve. The trochlear nerve contain. Okay.
We told trochlear nerve.
So we told trochlear nerve.
Trochlear nerve schwannomas. Trochlear nerve schwannoma along the course of the cysternal portion as we come from the opposite contralateral side. It will go to the cysternal portion, comes here. And there's because it resulting in there is atrophy of the superior oblique muscle. Typical. It may be patient present with the looking downwards, difficult. Okay. Superior oblique muscle atrophy, you cannot pass there. So you'll get 1 mark. 1 mark you said about superior oblique muscle. That only 1 mark. Okay. Okay.
1 out of 4.
Okay. Only 1 mark. Okay.
1 mark.
Okay. Now case number 8 for the team 8. So here team 8 will get some the evaluation of the evaluated for the chronic pain in the frontal region. This patient never had any surgery, but there is so you will get 2010 image of this one and 2014 and 17. Okay, but no surgery. We asked for no surgery was done. Okay, but having patient
septum ka hai iska.
But nobody done the surgery. So what is the diagnosis? What is the finding?
There is non-visualization of the nasal septum middle turbinate and the superior turbinates in the progressive scans, and there is fluid density in bilateral maxillary sinuses, and there is inferior medial defect in the orbital walls.
That all is there. Okay, sir. Okay, correct. Okay. Now, what do you think actually?
Sir, so, it is the bony resorption of the nasal septum.
Right.
And diagnosis could be, sir, sinusitis with bony septum, could be Wegener's granulomatosis.
Wegener's, correct. Okay, Wegener's can occur or okay. What should you look for?
Sir, additional findings we can look for lung cavitatory regions and lab investigation for.
Very nice, very nice. You will get this. So this patient had a surgery, never had a surgery, complete destruction of sinus septal wall. This is a lymphoid infiltrate with the necrotizing granulomas. As you said, it can be Wegener's or necrotizing granulomas or something related to exactly like Wegener's. Okay. So it is a Wegener's granulomatosis disease, but it can get other condition, cocaine, other trauma related, or maybe this is sarcoidosis, IgG4, they all can occur. So you'll get a full mark. That is full mark, 4 marks. Okay.
First team to get such thing till now.
Okay, very nice, very nice. Okay, thank you, congratulations. Okay, we'll go to the case number 9 for the team 9. This is a pain in both eye with the limitation of eye movement.
Yes, sir. Yes. Sir, there is hypodense soft tissue content in bilateral orbital cavity. Likely there is fatty deposition in soft tissue hypertrophy is there in bilateral orbital cavity. So it could be, sir, any chronic inflammatory disease like Tolosa-Hunt syndrome or orbital
Tolosa-Hunt syndrome, where is exactly? Tolosa-Hunt syndrome will not produce fatty changes. Sir, is there fatty?
There fat density in bilateral.
So what is the key finding? What is the diagnosis? What is the association? What is significant of this entity? Very, very important aspect. Okay. Dolasagan syndrome will vary like Dolasagan syndrome will be which part?
Sir, there is fatty deposition in and atrophy of muscles is there in bilateral orbital compartment.
Oh, what?
And bilateral optic nerves are prominent with.
That is not a fighting. Okay. 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 We'll move on to the next one. Okay. You'll get now the one fighting we said about this is how the muscle. Okay. Look at the muscle.
Fatty degeneration.
These muscles are at the replacement of fatty.
Progressive
External ophthalmoplegia. Skull.
Progressive.
Exactly. You know,
progressive external ophthalmoplegia.
it is a mitochondrial disorder. It carries by ptosis and the eye movement disturbances and the bulbar muscle weakness, proximal muscle. Very important aspect is can associated with because
mitochondrial disorder.
Can be, you know, A syndrome or more pigmented retinopathy and cardiac conductions.
Cardiac conduction.
So
Yes, sir.
you will get half point.
0.5 marks for team 9.
0.5 marks. Okay. So we'll go to the case number 10. So this patient was evaluated for a proptosis on both sides.
Bilateral proptosis.
Bilateral proptosis. Okay. So some more image.
Bilateral lacrimal glands are enlarged, sir.
Okay.
Lacrimal gland hypertrophy bilaterally.
Okay, finding what is actually anything significant here in the particular
Restriction. There is this
there,
restriction of diffusion is seen, sir.
So what is actually? What do you think? What
granulomatous disease, bilateral granulomatous sarcoidosis. Granulomatous disease bilateral hai.
Okay, this is the wrong answer. The wrong answer, but you said bilateral, that is will be there, but it will be easy finding. You know, important thing is there is diffusion restrictions. Okay, diffusion restrictions, very important thing. Common association. What is anything your common association? Unless you give diagnosis, you cannot do a common differentiate point from other diseases like
Epiderm.
It is
restricting, sir. Epidermoid.
It's not epidermoid. Muscle will not epidermoid. So the wrong answer. So that the only thing you said about the restriction finding is correct. Mark. Okay, 1 mark. So this is a lymphoma. Usually bilateral lymphoma. Lymphoma, you have that no highly cellular tumor with the restrictions. Okay, you can get in other conditions. Okay, Sjögren's syndrome and maybe other conditions, but granulomatous disease. But important than no orbital palpebral lobes of lacrimal gland involvement. With most important diffusion restriction, exactly the suggestion of lymphomas. Okay, that is low. Okay, so you'll get only 1 mark for the finding. Okay,
1 mark for team 10 out of 4.
ADC low restriction differentiate from the pseudotumor. Pseudotumor, we could I would have given the mark, but unfortunately, diffusion restriction will not occur there. Okay. Okay, next we'll move on to the case number 11. That is team 11.
Yes, sir.
2 years old child swelling in the right cheek since birth. So there are some images. Okay, the T1 and T2 and the T2 TSC, and I'll show some more images. And this is a T2 series images. Okay, the T2 TSC and PDTC. Go through completely. And what is most likely diagnosis? If you want, I will give some more images to see. And T1. T1. Get the picture and everything, you know, describe and got the part. So most important thing is the swelling cheek since birth.
IR light is dark only, no? So there is subcutaneous fat is hypertrophied on one side of the face.
Hypertrophy. Hypertrophy means what?
Thickened, which is appearing hyperintense on T2 and T1. In IR, it is suppressed.
Yes, so what?
So it can be a fat-containing lesion along the plane also, sir. Like
lesions, what fat content lesion will producing this type of appearance? Whether this is confined to one areas or maybe how that's I cannot lead questions, but
It is involving the masticator compartment also, sir.
So what is your most likely diagnosis? What are the key findings to predict the lesion? What is the significance? What suggestion to the clinicians?
Phases association. Hemihypertrophy.
Hemihypertrophy will not. I mean, look at these areas. This is congenital, traumatic, inflammatory, neoplastic, vascular. Like that goes on the order. So you'll get. So again, I'll tell you T1, T1, T2 fat suppression, and T1 fat suppression, and again PSC, and this is okay. T1 you can see. Okay, diagnosis will be it is a lipoblastomas. Okay, because it's occurring in younger age group, less than 2 years from birth. These are subcutaneous tissues become fat containing tissues with involvement of the prominent non-lipopatous component, also invariably it's called lipoblastomas. The natural history is very important. That is more important. It can be mature to lipoma or maybe some complete spontaneous dissolution, sir. That is a entity called lipoblastomatosis. Lipoblastomas only focal, lipoblastomatosis slightly wide range, infiltrated lesions. Okay, most important, what is important you should know, it is complete resolution occurs. Okay, so you'll get 1 point for the description of finding with fat containing lesions you said about it. Okay, 1 point for the team 11.
1 point for team 11.
Case number 12. This is an infant present with a nasal obstruction. This is can you see the images? Images have good. The clinicians.
Images are not.
Image, I mean, next one. So get history properly. Patient, infant, nasal obstruction. Clinician unable to pass the nasoenteric tube via the nasal rift nair. CT was done and further assessment of nasal obstruction. This is a finding. Already for the convenience for time being, I put arrow also. So what is the finding? So
nasolacrimal duct obstruction.
Nasal duct obstruction. Why?
Nasolacrimal duct.
Is there? No, there's already the nasal obstruction they'll mention about. So what is the finding? Important finding, which are finding will give the diagnosis. Okay, now I'll see the most important, then there is a what is called triad. So 3 important triad will give the 3 marks. Then make a diagnosis, 4 marks. 3 important triad of this particular disease process. So make a diagnosis will be open.
What's the key finding?
So you'll get arrow. You just see the arrow, you'll get the answer. Timing up.
NLD के पास में कुछ
nasal obstruction already patient having child. Okay, doesn't matter. Time is up. Okay, now important thing, this medial canthus mass. A middle canthus mass, as we seen in here, middle canthus mass, and there is important thing. There is a enlarged nasolacrimal canal, entire nasolacrimal canal, and the intranasal mass. Intranasal mass, all the 3 components make a nasolacrimal duct mucocele. Okay, very classical triad of this one. Once you get very easy to make a diagnosis with the 3 important triad. Okay. With this, you will get only 1 mark for the nasal obstruction and the nasal duct you said about. Only 1 mark. Okay.
Out of 4.
Okay. The team 12 will get only 1 mark. Okay. Thank you very much.
Thank you, Chidam sir. It was great collection of cases. We learned so much. In fact, I also learned so much.
Thank you very much. Thank you. All the best for the team members. Okay.
Okay, sir. Now I would like to update the score of all teams.
Okay.
Now the top team is team 2 with 8 marks. I told wrong marks. Last time they had earned totally of 4.5 marks. So the top team is team 2, followed by 2 teams. That is team 1, 7.5 mark, team 10, 7.5 mark, followed by 7 mark of team 8, then 6 marks of team 3, team 6, 6 marks again, followed by 5 marks each of team 11 and 12, followed by 4.5 marks each of team 4 and 5. And finally, the last is team 7, that is 3.5 marks.
Okay, all the best for the team. I hope that all the people actually enjoy the cases and all the best for your team. Okay, thank you very much.
Thank you. Thank you.
Cases I shown already in the various forum. Okay, thank you. Thank you very much.
Okay. It has been a very heavy this thing. So we'll introduce a very ultra short session by Sikandar sir for physics. Then we'll go to the respiratory system. Ultra short session by Sikandar sir for physics.
Thank you, Dr. Gaurang. I think after Chidambaranathan sir, definitely it has to be ultra short and very precise. And for your information and audience information, Dr. Chidambaranathan sir was my teacher when I was in Apollo Chennai. So it's a pleasure and little difficult also because sir has shown so many excellent collections. So yeah, thank you, sir. And I owe a lot to you because you have made me what I am today. So a lot of credit goes to you and Apollo Hospitals.
That is your work.
Where I have worked.
Very good. Your work, you are doing the job. Fantastic. Please, all the best. Thank you.
Yeah, thank you.
Okay.
So without taking much time, so I am coming. Is my screen visible?
Yes, sir. Yes, sir. We can go ahead.
Audible?
Absolutely, sir.
Yes. Yeah. So I will be starting with the time is 30 seconds. Please make a note, everyone. The time is 30 seconds. And they are nothing to worry. They are very straightforward. First 1 to 12 teams, I will go physics. Then again, I will come back 1 to 12 with nuclear medicine questions. So each question has 30 seconds. Please make a note of this. And you have to answer within this. And they are very straightforward answers. If you give complete answer, it is 1 mark. If it is 1 mark, if it is half answer, then half mark will be given. And if you don't answer, then there is no mark. Then I will proceed to the next team. So any queries, any doubts without, then I can move on. So this is first. Yes. Question to team 1. Very simple. The main contribution to differences in X-ray attenuation in diagnostic imaging is known as. I'm repeating, main contribution to differences in X-ray attenuation in diagnostic imaging is known as. Team 1. 10 seconds.
Contrast resolution.
Contrast resolution. Yeah, it's wrong answer. So it is a photoelectric absorption. So it is also a process in which the incident X-ray or gamma ray photon interacts with the atom of absorbing material and the photon completely disappears. Its energy is transferred to one of the orbital electrons of the atom. So what you told is something very clue, but I won't give you even half mark because this is most commonly used to improve the contrast while using contrast agents. So remember photoelectric absorption. So 0 mark to team 1.
For team 1. Team 2.
Yeah, team 2 ready?
Yes, sir.
Okay. Yeah. This is a X-ray beam. What does A, B, and C
Absorption,
stand for?
reflection. Sir, A is refraction, B is absorption, and C is scatter. Reflection.
Refraction and first is it's
No, you told 2 things wrong.
No, we told B is
Sir, B
absorption
and
and C is
absorption, C
scatter.
and scatter.
So you'll get half mark in this.
0.5 mark for team.
0.5. Okay. Team 3. Team 3 ready? Team,
Yes, sir.
3 ready?
Yes, sir.
Okay. Compton attenuation coefficient is equal to dash by energy. Compton attenuating coefficient is equal to dash by energy.
Z of the material.
Can you precise it?
It is the molecular weight of the material that the X-ray is being X-rays on which the X-rays I mean on which the X-ray is projected.
Independent of
Your time is up.
electrons per gram.
And Z,
It is a density by energy.
ma'am, sir, but Z density depends on Z.
That's
Number
why I asked you what does. Please specify. Don't tell Z. Z means you have to define and clearly mention it. So you'll get half mark here.
0.5 marks for
0.5 marks for team 3. Team 4, are you ready? So question to team 4. What is a focal track in anode? Focal track in anode.
It's the part of the anode that actually produces the X-rays.
Anything beyond that? Last 5 seconds. Yeah, your time is up. It is a portion of the anode where the electrons are bombarded. And on a rotating anode, this is a circular path, if you see this. So this is a focal track and this is a focal area. So these two are different entities. So please make a difference. And this anode is again also made up of tungsten and having thermal qualities. And this is designed to rotate during the operation, and cathode is positioned in relation to the anode in the tube, and the electron stream which is striking the lower part of the disc along with the area is known as focal track. So this is something like which will be rotating completely. So you don't get any mark. So
0 marks for team 4.
Team 4. Now team 5 ready?
So
okay. What is meant by fast KVP switch? Fast KVP switch and DECT. Dual energy CT.
changes in the MAS. So changes, fast changes in the KVP, sir. In the it is done between 80 to 120, sir. Fast it is converted, sir. KVP is
changes between contrast and noise.
Okay. So I think you have described it. So it is a tube, like it switches rapidly between high and low tube potential multiple times. Within the same rotation is known as fast KVP switch. So KVP switch is between the higher and lower tube potentials. Okay. So half mark to you.
0.5 for team 5.
0.5. So these are certain things. Remember about this. It can be consecutive, it can be sequential. And this is again in relation with the changes in the potential. So team 6, are you ready?
Yes, sir.
What is a half value layer? Half value layer HVL in X-ray attenuation.
That is the thickness of the material which reduces the X-ray attenuation by half. So it is used in radiation protection, say, like the lead layer thickness, the 0.5 mm of lead will be equal to some 23 mm of brick. Like that, it will attenuate the X-rays. It is a value of the attenuating power of the material.
Okay, so if it is less attenuation, what will happen?
Sir, if it is less attenuating, it will have a higher half value layer. You will need more material to attenuate it.
Okay. Can you tell in a different way? Actually, you are precisely correct, but it is a measure of penetrating power of the X-ray beam. Okay. Penetrating power of X-ray beam and is the amount of matter required to attenuate the beam
to
to half its energy value. So this is the thing which you have told. Okay. And this, the smaller the HVL, the more attenuating the material is, or weaker the X-ray beam. So this smaller HVL means it is directly proportional to the weaker X-ray beam, and it needs more attenuating the material. So that it differs from different materials and strength of the beams from where the exposure has to be done and what is the strength of a beam which is coming up. Okay. So you have told half of this explained clearly. So you have to be more precise. So you'll get half mark. Team 6, 0.5 mark.
0.5 marks for team 6.
Yeah. Thank you. Now team 7, are you ready?
Yes, sir.
What is a transverse decay in T1 weighted sequence? What is a transverse decay in T1 weighted sequence MR?
It is the time taken for the pulse to that is time taken to gain the 63% of the radio frequency pulse wave which is given horizontal decay.
Anything better explanation? What do you mean by decay?
Sir, if we give a radio frequency pulse, it will first go to the z-axis, that is horizontal plane, then it will slowly decays to the vertical plane. The time taken for the radio frequency pulse to attain that 63% of the horizontal plane is called transverse decay in T1 weighted image.
Your time is up. So it is a rate at which the transverse magnetization is lost. It is related with transverse magnetization which is lost and determined by the magnetic interaction between the spins. And this phenomena is also known as spin-spin phenomena or transverse decay. Okay. So you have told something different. So you get 0 mark here. Team 7, 0.
Team 7, 0 marks.
Teammate, are you ready?
Yes, sir.
What is a pulse repetition frequency in ultrasound? PRF. Twenty seconds.
Half of
10 seconds. 5.
Sir, it's used in Doppler ultrasound and it measures the.
Your time is up.
0 marks for teammate.
Yeah. Yeah. It is a scan line density in a number of beams sent out by the transducer to the sample the patient tissues per frame. For example, you have 30 frames per second. Each of 100 lines per frame requires a PRF of 3 kilohertz. So please, when you use the ultrasound, this is very important knobology there. So you have to know about this. Try to read entire knobology. So teammate 0 marks. Team 9, are you ready?
Yes, sir. Yes, sir.
Yeah. Your question. What is the principle of bioluminescence imaging? What is the principle of bioluminescence imaging?
Sense imaging is used in the
Seconds. Ten seconds.
It is the production of
Time up.
visible light due to the.
Your time is up.
0 marks.
So it is one of the phenomena where the imaging, it is a part of molecular imaging using biochemical reaction of enzyme luciferase. So luciferase is an important entity where the chemical reaction occurs and there is a detectable photon is produced. So this is a part and parcel of the molecular imaging. Okay, so 0 mark to team 9. Team 10, are you ready?
Yes, sir.
Electronic dosimeter. Most commonly used electronic dosimeter is dash detector. Dash detector. 20 seconds.
TLD, sir.
10 seconds.
Sir, semiconductor detect.
5.
Sir, it detects beta, X-ray, beta, gamma, and X.
0.
Yeah. So time is up. 0 mark. So it is a very highly sensitive dosimeter. It's more sensitive than our TLD. And the most commonly used detector is a silicon diode. So it can detect a small, very more sensitive or highly sensitive, and still having a higher mechanical stability for detection of a very small amount of the radioactivity. So this is more sensitive than TLD. So you get 0 mark. Team 11, are you ready?
Yes, sir.
What is the formula of Planck's constant?
Sir, pass, sir. Pass.
Pass.
0.
Don't want to attempt. Hello?
Yes, sir. They don't want to attempt. 0 marks.
0 marks. Okay. So the answer is E equal to hf. So E is photon energy, h is Planck's constant, which is measured as 6.63 into 10-34 milli 2 kgs per second, and f is frequency. So where is it important? Planck's constant is the product of energy multiplied by time. So here, when we are quantifying the amount of energy of X-rays or any energy, so this Planck's constant is defined, and it is also a part of elementary quantum of action. So 0 mark to team 11. So team 12 ready?
Yes, sir.
What is the phenomenon of heating of metallic objects in MR? What is the phenomena of heating of metallic objects in MR?
He's being specific absorption. Is saying no, that is normal objects. No.
20 seconds.
SCR metallic convex. Why?
5 seconds.
SAR.
Time up. So this is caused by the RF frequency wave. It is also due to resonant antenna effect, where RF pulses are setting up a standing voltage wave in the metal, causing tips of wires to undergo rapid heating and burn the patient. So please remember, this is also one of the important entity, especially related with the MR safety. Okay, so you get 0 mark. So now going back. Gaurang sir, I'm starting with nuclear.
Yes, sir. We can.
Back to team 1. Team 1, are you ready?
Yes, sir.
Team 1. Okay.
Yes, sir.
This is a nuclear medicine. Yeah. So name the reactor produce radioisotopes used in lung ventilation scan having half-life of 13 seconds. Lung ventilation scan. 20 seconds.
So,
10
helium.
seconds. Yeah.
Helium.
Helium. No, your time is up. So it is a krypton which has a half-life of 13 seconds. But other thing, please remember this, lung ventilation scan is different and perfusion scan is different. So in ventilation, the lowest half-life is 13 seconds is krypton 81. But xenon and 99 technetium DTPA is also used, just for your information. And lung has a perfusion scan which again uses 99 technetium. So 0 mark to team 1.
0 mark. Team 1, 0 mark.
Team 2 ready?
Yes, sir.
Tetrophosmine is a radioisotope used for which organ evaluation?
Sir, prostrate? Liver?
Wrong answer.
0 mark.
0. It is used for parathyroid function. It is also known as alloy, which is also 99M technetium system EB scan. Please make a note. This is commonly asked questions in your whatever exams. And patient is scanned at 20 minutes and 2 hours after injection for parathyroid function. So 0 mark to team 2. Team 3, are you ready?
Yes, sir.
AK DAT scan is used for evaluation of which organ? 20 seconds.
Brain.
Brain.
Hmm?
Brain.
Brain. Anything particular in brain?
Parkinsonism.
Huh?
Parkinsonism.
Perfect. You get 1 mark. So it is for imaging of Parkinson's disease, also known as iodine 123 ioflupane SPECT scan. And in this, thyroid is blocked so that there is no uptake seen in thyroid gland. And patient is imaged 3 to 6 hours after injection. So perfect, very good. So you get 1 mark. Team 3 directly get 1 mark. Team 4, are you ready? Ready?
Yes, sir.
Okay. What is the role of converging hole in gamma camera? Converging hole in gamma camera.
To avoid scattering. To avoid scattering.
Scattering.
To like detect all the particles without
Wrong answer. So it is for magnifying the image actually. So there can be single hole or multiple holes when they can converge at a central point, providing a magnified image with better spatial resolution. So converging hole. So team 4 gets 0 mark.
0 marks for team 4.
Team 5, ready? This is your question. Team 5.
Yes, sir.
Scintillating crystal in gamma camera is made up of.
Sodium iodide, sir.
Thallium activated
Thallium.
sodium iodide.
Thallium.
Thallium
Sodium
activated.
iodide, sir.
Why do you think it is? Yes,
Because
perfect. You get 1 mark total. Very good. So it is a single crystal of sodium iodide with a small amount of thallium. Okay. So this is scintillating crystal which is there. The concept is to produce a burst of light when gamma rays are hit and light is picked up by these detectors located behind the crystal, and electrical output from detectors is fed up to the computer to produce the image. So very good. Team 6, are you ready?
Yes, sir.
Yes, sir.
What are types of planar imaging in gamma camera? What are types of planar imaging in gamma camera?
Horizontal, vertical. Parallel.
Parallel and anti-parallel.
Your time is up. So it is a static scan, dynamic scan, and gated scan. Static scan, we do DMSA, renal, bone, and lung perfusion. Dynamic is when you are injecting, that is MAC3 renal scan, gallbladder or emptying scan, or Bulida scan, or gastric emptying scan. And gated is always cardiac gated blood pool imaging. So these are types of planar imaging. So you get 0 mark. Team 6, 0 marks.
0.
Team 7, are you ready?
Yes.
What are types of camera oblique detectors in SPECT?
Gamma camera.
Camera oblique detectors in SPECT.
Gamma camera.
Gamma camera. So your answer is wrong. It is single head gamma camera. If you would have seen the gamma camera actually, it has a single head or multiple heads. So preferably it will be single or double head, and nowadays we are getting multiple head. So dual will have 2, single will have single. So again, the scan time is based on this exponentially. Single head will be having more time. Dual means 2 cameras, so it will be half the time. And multiple 3 or 4 means again the scan time will be reduced. So each rotation is again based on number of heads actually. So you get 0 mark, team 7 0 marks. Teammate, are you ready? Teammate.
Yes, sir.
Okay. Time of flight in PET refers to what? Time of flight in PET.
Is the time taken for the
So difference in the arrival of the two photons
in the target tissue?
in the target tissue for precision.
Can you be a little more precise? Your time is up. So it refers to detection of positron annihilation photons. So this is important. Annihilation process, this word you have to mention. So it is detection of positron annihilation protons, which are extremely having high temporal accuracy for better PET image quality. So you get 0 mark. Teammate 0 mark. Team 9, are you ready?
Yes, sir. Yes.
So what should be the energy from annihilation process to be released in form of 2 photons in PET?
Energy. Scintillation.
Energy from annihilation process to be released in the form of 2 photons.
What is that?
5 kilo electron volts per second.
Your time is up. So it's very simple. It is 511 kV, 511 kV at 180 degrees. So if it is a rounded gantry, the angle has to be 180 degree and the amount of energy is 511 kV based on the Einstein's principle. So please make a note of this. So you get 0 mark. Team 9 0.
9-0.
Team 10, are you ready?
Yes. Yes.
What is the dead time in PET scan machine? What is the dead time in the PET scan machine?
Time.
So the minimum time between two consecutive recorded events that we are taking, sir.
Your time is up. So it is a time following the detection in which detector is insensitive. Detector is not sensitive to further incident gamma photons, which are calculated and counts are corrected. The name itself dead means it is insensitive or inactive. Okay. So get 0 mark, team 10.
0 mark, team 10.
Team 11, are you ready?
Yes, sir.
What is the line between two detector elements in PET gantry called as?
Line of correlation.
Line of?
Correlations.
It's a wrong answer. It is a line of response. Okay. So we get 0 mark, team 11.
0 marks to team 11.
Team 12, are you ready?
Yes, sir.
Truncation artifacts seen in the PET and SPECT. Sorry, spelling is wrong. It is seen in the PET and SPECT are due to truncation artifacts.
Quantum modeling is tell that. Quantum modeling. Tell that. No.
So quantum model.
It's inspect. The truncation artifact inspect is when the field of view is larger than CT field of view and no CT data available for attenuation correction in the SPECT images. Okay, PET and SPECT images. So you didn't give the answer. So 0 marks to you. So I think I have covered everything. I just want to tell one thing. Physics is very important. These are basic things, basic questions which are being asked in our routine FRCR and MICR exams also. So don't get confused. The concept of physics has to be understood very properly. And it's like whatever you have done, I thanks all the participants. Good efforts by all of you. So over to Gaurang sir. My session is over.
Thank you, Sikandar sir. Thank you. I would just like to update all the scores for everybody. So right now the top team is team 2, followed by that is 8.5 marks, followed by 7.5 marks of 3 teams, that is team 1, team 3, and team 10. Then we have 7 marks of team 8, followed by 6 marks of team 5, 6.5 marks of team 6, then 6 marks of team 5. And then I'll just read out. Team 4 has 4.5 marks, team 7 has 3.5 marks, team 9 3.5, team 11 and 12 5 marks each. We now go to Dr. Nitin Gonge sir for the respiratory system. Good evening, sir.
Good evening, everyone. So I hope we have a tough fight between the top 5 teams now.
Yes.
So Gaurang must be giving the regular updates so that you can accordingly gear up for the top 5 slot. So the respiratory system, I will just share my screen. So everyone can see the screen?
Yes, sir.
Okay, so let me explain the format for this round. It is not going to take a long time and it will be quite objective. I have just 12 questions. One question goes to each team, right from team 1 to team 12, and each case has 2 slides. So in respiratory system, the chest radiograph is the most important thing. So slide 1 will have a single chest radiograph. So if you can just quickly describe the finding and give the diagnosis, then you will get +2 marks. That is a complete mark based on the slide 1 itself. And the slide 2 is the cross-sectional imaging, CT or MRI of the same case. And if you give the correct answer on the slide 2, that is based on cross-sectional imaging, then you will get only +1 marks. So no negative markings, and if you don't attempt, don't give answer, then you will remain at the same marks. So +2 if you give answer only on chest radiograph, and +1 if you give answer on CT or MRI of the same patient. Is it clear? So we'll start with team 1. So no clinical history, just a chest radiograph here. So not only diagnosis, just a brief finding, and the diagnosis will give you the marks. Total marks is +2 for each case.
So I will diagnose one problem. So mediastinal widening with a hilum overlay sensor.
What else? Just mention the findings and the diagnosis.
Cross-sectional images.
So you want to try any diagnosis on this? Your findings are not optimal though. So we will move to the next slide. This is the cross-sectional imaging.
Lymphomas. Okay. Yes, correct. So, though you could not make out the findings correctly on chest radiograph, but you correctly mentioned the diagnosis as lymphoma, so you will get the correct +1 mark. Though chest radiograph itself gives the diagnosis, and this was the very good case to pick up complete 2 marks, because you can see enlarged lymph nodes in the mediastinum on both sides, paratracheal and even subcarinal, and then you can even see the axillary lymph nodes on both sides. So this is characteristically lymphoma, as we can see the non-necrotic lymph nodes in the axilla and the mediastinal regions on CT as well. So +1 mark to team 1, Gaurang.
1 for team 1.
Yeah. So we move to team 2. Team 2, you are ready?
Yes, sir.
So the answer for case 1 was lymphoma, mediastinal and axillary lymph nodal enlargement, so lymphoma. So going to team 2. Case 2.
Sir, straightening of the left heart border. This could be due to mitral stenosis. Also,
Peribronchial, tubular, not tubular dilated structures.
How will you describe?
So there is a widening, swelling of the carina.
Yes.
Straightening of left heart border. The left bronchus is.
also there is a double contour along the right heart border.
Anything else very prominently?
Sir,
What
bilateral.
makes the left heart border?
Left atrial appendage is pulmonary artery. Yeah.
What is happening to pulmonary arteries?
So the left one is dilated and causing bulge.
So what should
Okay,
be the
bilateral
prominent vascular
prominent
markings.
vascular markings in bilateral lung fields.
So do you want to attempt the diagnosis on this, or you want a cross-sectional imaging?
क्रॉस सेक्शनल नहीं, बट ये नहीं हो सकता ना क्रॉस सेक्शनल. सर क्रॉस सेक्शन इमेजिंग.
Okay, CTA, mediastinal and lung windows.
Reflex again.
So the third image is not is half of the third image can be seen, not the full.
I can see the full image. Full image is clear.
So there is reflux of the right atrium is markedly dilated. Also, there is reflux of contrast in the IVC and the hepatic veins.
Also, there is a filling defect in the SAC.
Okay, so what is your diagnosis?
SVC syndrome नहीं होगा ना.
I think time is up.
Right heart failure.
Okay, so I
Because
think
of pulmonary hypertension, pulmonary artery hypertension.
okay, I will give you half mark definitely, because you took a lot of time. You mentioned the findings to a certain extent: widening of the carina, enlargement of the left pulmonary artery, gross cardiomegaly is there, and you can see there is dilatation of the pulmonary artery, and you can see it is more dilated than aorta. RA, RV enlargement, reflux is there, and very characteristically you can see the ground glass haze, particularly in perivascular region. So this is a characteristic finding. These findings says that there is pulmonary arterial dilatation, and this says that this is a primary PH, not a secondary PH. Perivascular ground glass opacity suggests primary PH. So you have described the, you have on CT you mentioned pulmonary arterial hypertension, though that was the diagnosis on chest radiograph itself. If here you would have mentioned primary PH, then I would have given you 1 mark, but you will only get half a mark, 0.5 mark, Gaurang.
0.5 marks for team 2.
Yeah. Okay. So this is primary pulmonary arterial hypertension, and it is important to differentiate primary PH with secondary, that is CT EPH, that is secondary to chronic thromboembolism. So team 3, you are ready?
Yes, sir. Yes, sir.
So this is your radiograph chest.
Sarcoidosis. Okay.
So there is fibrotic opacity. কি বলছিস তুই?
Ill-defined opacity around the right hilar region, and the right lung pulse is relatively hyperinflated compared to left lung pulse.
What is the reason?
তোর diagnosis কি?
What is the reason for the difference in the lucency?
Pectoralis muscle Swyer-James syndrome. হতে পারে কি?
Is there any breast shadow difference?
না,
এখানে breast shadow আছে না নেই?
any bronchial atrophy,
No,
like
breast shadow টা দেখ, breast
bronchial
shadow.
cut.
Look at the breast shadow.
Both of you make a consensus and let me know the findings so that we can decide.
Breast shadow nahi.
There is no breast shadow on right side.
Okay, what does it mean?
That means
Mastectomy. Patient
mastectomy.
undergone mastectomy.
Yes.
Then what does it mean for the changes in the lungs?
The lesion can be any metastasis.
So what is the diagnosis?
CA breast with metastasis.
No, not metastasis.
Okay, I will show the cross-sectional image. Now, what is the final diagnosis?
Ito metastasis signal lesion আছে.
That is metastasis. We'll go for metastasis.
We'll go for metastasis, sir. In a case of post-operative CA breast.
So you correctly mentioned patient is a CA breast case, mastectomy is done, but you can see the collapse consolidation here. But you can also see the significant changes of
hilar mass can be there.
Interstitial thickening, reticular interstitial thickening is seen because of the lymphangitic changes. Lymphangitic changes are there. So you have mentioned metastasis. So and CA breast, you correctly picked up mastectomy. That is very important in this case. The correct answer is the right-sided mastectomy with pulmonary interstitial thickening, nodularity. With important is despite the interstitial thickening, the architecture is all preserved. So CA breast में pulmonary lymphangitic carcinomatosis is an important form of complication. Is the correct answer. So here you are going to get, I think, 1 mark because you mentioned CA breast mastectomy and you also mentioned metastasis. Though it is not a parenchymal mite, it is a lymphangitic form of spread. So 1 mark to team 3.
One mark for team 3.
Yeah. So going to case number 4. Team 4, you are ready?
Yes, yes, sir.
So your patient is a 48 years male with acute chest pain.
That is not wrapped in there is diffuse interstitial thickening on both lung fields, and there is a there's a double density sign which will indicate a left atrial hypertrophy, and I can see some calcification in the arch of aorta. So
the history is quite important. That's why I'm telling you the history.
We'll go CT cross-section.
Okay. So we have NCCT and we have MRI contrast. T2 weighted MRI.
Is a ruptured aortic aneurysm?
Yes, correct. So you have seen acute chest pain, 48 years male, and you can see a focal dilatation with peripheral calcification, and then focal area of collapse consolidation in the left upper lobe. And the CT again showed this is broken ribs, the discontinuity of the calcification at a is seen here, and this is you can see the aneurysm which is showing adjoining ground glass haze with significant inflammatory changes in the left upper lobe. So this is leaking or ruptured aneurysm of the aortic arch. So team 4 gets 1 mark plus 1 mark.
1 mark for team 4.
Okay, so we go to case 5, that is team 5. You are ready? So this case is a 10 years male who presented with acute onset fever and cough.
The areas of patchy homogeneous opacity noted in the right upper and middle lung zone with LV pattern cardiomegaly and straightening of the left heart border.
Then you have a 1 week later, there is another chest radiograph.
It has increased, sir. CPAP, acute onset.
Acute onset fever and cough.
Round pneumonia. Round pneumonia can be the consolidation and
any other
sir,
finding you can see. Any other
staph,
finding
because
you can see.
cavity lesions are also seen in the cavitation, so it's likely staph pneumonia, sir.
Yes, yes. So, do you want to comment on CT as well?
So there is also rupture of the pneumatocoel, sir. Basically bulla rupture is there after cavity, and there is a associated pneumothorax, and there are multiple cavity lesions, sir.
Yes, very good. And this progresses between the two radiographs as well. So the team 5 gets +2 marks because they correctly mentioned pneumonitis,
Okay.
cystic changes, and staphylococcal pneumonia with pneumatocoel. So they correctly mentioned the finding and the diagnosis on chest radiograph itself. So they get +2. Okay, team 6.
Yes, sir.
So your case is here.
There is
Cystic lucencies.
cystic lucencies in the left the
Left lower zone and
shift of mediastinum and trachea to the left. There is some volume loss also on the left side. Cystic things, CPAM and all is not possible. Huh?
Yes, your description findings are quite correct. What do you suspect is the cause?
CPAM.
What else?
Multiple cystic lucencies.
Look at the vascular structures.
Iota is fine.
Okay, how do you proceed? Diagnosis or further investigation?
The high is like this.
further
CT.
CT.
Cystic bronchiectasis.
With volume loss of the volume loss of that ipsilateral lung, and there is compensatory hyperinflation of that opposite side.
What is the cause?
Left lobe bronchiectasis.
Bronchiectasis is the cause or sequelae?
Sequelae of the
this bronchomegaly. There is so much part is in the correct side.
Can you comment on the vascular structures on this? You have 10 seconds, otherwise we will stop.
compression. Compressions.
Okay, so your time is over. So here you can see the right pulmonary artery very nicely, but here you don't see the pulmonary artery. Hilar structures are not clear. The left lung is quite small. That's why diaphragm is elevated, heart is elevated, and you can see cystic bronchiectatic changes. The left lung is quite small, and the reason, and you again can see the same changes on the CT, but characteristically you can see the very small pulmonary artery. So this is because of the post-infective obliterative bronchiolitis, what is called a Sever-James syndrome. So it leads to small size pulmonary artery where at times there can be complete agenesis, but that is a developmental condition. But this is a developmental condition. At times there is complete agenesis, which is also close differential of Sever-James syndrome. So you get only half mark because you describe the findings, but you cannot reach to the correct diagnosis even on CT. So 0.5 marks to team 6.
0.5 marks to team 6.
So team 7, you are ready?
Yes, sir.
So this is your radiograph. Chest.
There is patchy area.
Sorry. Okay.
So we can see a radio opacity
Yeah.
involving the left to middle zone with showing air crescent sign. We can also see another radio opacity in the right middle zone, most commonly with slight prominence of main pulmonary arteries also seen. Considering the this is some so considering the air foci is something cavitatory lesion, most probably fungal, aspergilloma.
So you are able to see the crescent on X-ray itself, or you saw it on CT when I accidentally changed the slide?
It's a decrease.
Okay, because you correctly picked up this focal lesion here with a crescent which is non-dependent, and we can see the same crescent here in the left lung, and this is because of the saprophytic aspergillosis. So they get correct full marks. Gorang +2 to team 7.
Marks to team 7.
So next is a team 8.
Yes, sir.
Yes, sir.
So this is your case.
Diaphragmatic hernia. Obesity, right?
Sir, there is a radiolucency in the region of left CP angle and left lower lung zones. And there is
Causing
mediastinal shift towards the right side with areas of
NG2
radiopacities in the entire right lung, like the collapse consolidation. And in the radiolucency, we can see the NG tube. So
Is in the thorax.
it is in the thorax. The diagnosis
Diaphragmatic hernia.
would be likely diaphragmatic hernia causing mediastinal shift to the right side.
Okay, you want to see the next scan?
Yes, sir.
What is the final diagnosis?
So
diaphragmatic
rupture with herniation of stomach into the left hemithorax with nasogastric tube in situ and mediastinal shift to the right.
Yes, correct. Apart from that, there is a scapular fracture, rib fractures as well. So
Post-traumatic.
they correctly mentioned post-traumatic. Even you should have seen this MLC labeled here. So diaphragmatic hernia, post-traumatic rupture of the diaphragm. They correctly mentioned the findings on CT as well as on the radiograph. So they get +2. Team 8 gets +2. Okay, team 9, you are ready?
Yes, sir. Yes.
So 55 years male with recent onset hoarseness of voice.
There is a well-defined radio opacity seen involving the left hilar region with hilum overlay sign seen. Surrounding lung appears normal and
On the basis of, sir, my finding, it could be the case of Ottner syndrome, in which because of enlargement of left atrium, there is compression of vagus nerve.
Yes, very good. Very good. Now you want to describe the findings on CT?
Sir, there is hyperdense enhancing lesion seen in subcarinal retrotracheal region, likely in communication with descending aorta. It is likely the pseudoaneurysm of descending aorta.
So this is a spontaneous aneurysm of ductus arteriosus, and this is causing compression over the left recurrent laryngeal nerve. So this is a case of cardiovocal syndrome or Ottner syndrome. So they get +2 points. So team 9 gets +2 points. Okay, case 10. Team 10, you are ready?
Yes, sir.
Okay.
So radiograph chest posterior anterior view. There is uh, blunting of left CP angle is seen, sir. There is a soft tissue density mass lesion noted in the mediastinum, sir. Which is extending into the neck. The soft tissue density lesion is extending into neck.
Okay, what are the possible reasons?
Mediastinal mass can be, sir, either a lymph nodal mass or a thyroidal mass which is extending to the neck. Because the
What is the consequent mass effect?
Narrowing of the trachea.
Narrowing of the trachea is deviated towards the right, sir. Deviated and narrowing of the trachea is seen on X-ray. So the narrowing of trachea and is deviated towards the right side.
You want to comment on the lungs?
Lungs, so there is 2, 3, 4, 6. Hyperinflated lung. nahi.
Okay, so what is the diagnosis?
Likely a retrosternal goiter, sir.
Okay, I will show you the next slide.
So there is an anterior mediastinal mass which is causing deviation of the trachea towards the right side. Multiple calcific densities are noted within this lesion. And sir, okay, miliary nodules are seen. Tuberculosis effusion bhi tha.
So what is the diagnosis?
Tuberculosis. Miliary TB with mediastinal lymphadenopathy, miliary nodules, and pleural effusions.
Wrong diagnosis. You very nicely picked up the tracheal compression and the lesion in the mediastinum, but this was a very good pickup. But you can see a focal lesion with microcalcification.
Sir, thyroid.
This is a papillary carcinoma thyroid.
Papillary thyroid, sir.
This is a papillary carcinoma thyroid with calcific mets. So you mentioned it as TB, which was not a diagnosis at all, looking at the CT. So you will get only half a mark, 0.5 marks. Okay, so team 11, you are ready?
Yes, sir.
So this is your case.
Sir, ill-defined opacities seen in bilateral midzone of the lungs with few mediastinal nodes are seen.
Can you further describe the lesions, opacities?
So opacities are both nodular opacities are also seen within, sir. It is perihilar. So a provisional diagnosis could be progressive massive fibrosis
Bilateral.
or a bat wing appearance. It could be.
Okay, I will show you the CT scan.
There is interstitial thickening with nodular opacities. Could be sarcoidosis.
Yes, why do you say sarcoidosis?
We are seeing both interstitial thickening with nodules, sir, along the interstitium.
Multiple nodules along the
And
peribronchoascular
periphyseal
interstitium
nodules are also there.
and multiple lymph nodes also. So this is clearly a sarcoidosis. Rather, you could have mentioned this on radiograph also, because we can see sarcoid galaxy sign, more confluent nodules and the center, less nodules in the periphery. So this is clearly a sarcoidosis, and you get +1 mark because you mentioned the correct diagnosis on second slide.
For
So
team 11.
yeah. So we go to team 12. Team 12, you are ready?
Yes, sir.
So this is your case.
A large, well-defined radiopacity in the left upper and mid zone. Vessels can be seen. Vessels can be seen coursing through the mass and not silhouetting the right heart border, and widening widening of the posterior ribs. This is likely a posterior mediastinal mass.
Okay. So, what is the most likely diagnosis?
Neurogenic tumor.
Okay. So I will show you the CT.
Arising from the foraminal extension is also again a homogeneously enhancing soft tissue mass in the left paravertebral region. Foraminal extension. Destruction possible. It's okay, but can we
What is the compartment of the lesion? What is the organ area origin? It is arising from which structure?
vertebral.
And what is the morphology of the lesion? What is happening? What is the attenuation?
So it's homogeneous enhancing.
Does this calcification suggest something?
So neuroblastoma could be a possibility.
Okay, think of any differential. You have 10 seconds. That's all.
Neuroblastoma. This
Time up.
Okay, so you correctly mentioned it as the lesion in the mediastinum or posteriorly because of the Silhouette sign, but and very correctly you mentioned this widening of the ribs. So it is a rib chest wall lesion because of the rib widening, and then you can see the ring and arcs pattern of calcification in the lesion. So this is a rib chondrosarcoma. Chondrosarcoma of the rib is the correct answer. Your description was good on X-rays. That's why I will only give you 0.5 mark. Otherwise, the diagnosis is not correct. So 0.5 marks to team 12.
0.5 marks to team 12. Thank you so
Yeah.
much. I think now the competition has increased, and sir, we
Okay.
need you for a tiebreaker SOS. So please, if you could remain.
Okay.
I'll just tell the scoring right now. Right now, we have two teams on the top slot. That is team 2 and team 8, both at 9 marks, followed by two teams, that is team 1 and team 3 at 8.5 marks. Then we have again two teams at 8 marks, that is team 5 and team 10. And then I'll just read out the marks of rest of the team, that is team 4 with 5.5 marks, team 6 with 7 marks, team 7 with 5.5 marks, team 9 with 5.5 marks, team 11 with 6 marks, and team 12 with 5.5 marks. Over to Naveen sir, who has been waiting patiently with us for a wonderful session of GIT and GOT. Naveen sir, good evening.
Good evening, sir. Can you hear me, sir?
Yes, sir, absolutely loud and clear. We would like to proceed further with your sections.
I'll share my screen, sir. Can you able to see my screen?
Yes, sir.
So first we will go with the GIT, sir.
Okay, sir.
Yeah, thank you for IRI for giving me this opportunity. So the first question is for team 1, I think. So he's a 35-year male patient, came with the complaints of pain abdomen since 3 days, related to back with burning micturition. So what is the most probable diagnosis and what is the sign which is seen in this case? Team 1.
Sí, sí, a ver. Sí, sí, de nada, sí, sí.
Left renal cell carcinoma with emphysema.
No, it's a wrong one. So you can see where is the lesion arising from. Is it from the kidney? It's not arising from the kidney. We are discussing about GIT. And where will the question of kidney can come?
Sir, carcinoid.
Carcinoid is also the wrong answer.
No.
What is this lesion? Where this lesion? Can you see this lesion?
Rising from bowel wall.
Yeah. What is this lesion?
Just
Yeah. So why you have considered GIST for this diagnosis?
the extraluminal ectophatic lesion arising from the bowel wall.
Okay, and what is the sign which is seen in this case? Okay, next, what is the most sensitive and specific tumor marker for this entity?
Dog one.
What?
Dog one. Here 67.
Can you repeat again? What is the
dog one, sir?
DOG1?
Yeah.
Yeah, right. It's the most sensitive and specific marker. So you can see this is a gastrointestinal stroma tumor, and this is Torricelli Bernoulli sign because there is non-dependent air trapped in the necrotic ulcer. You can see this is the free air which is there in the necrotic ulcer in the case of a GIST. So this is Torricelli Bernoulli sign, and the most sensitive marker is DOG1, that is discovered on GIST1 or anectomin. This is the most sensitive and specific marker for GIST. So first question they will get half marks, sir. Second one is 1.5, sir.
1.5 marks for team 1.
Team 1, yeah. Next we'll go to question 2. Team 2. Team 2. So you see the images, and what is the most important imaging appearance shown in this case, and mention few causes which can produce similar imaging appearance. So you have to tell the diagnosis.
Absolutely. So the significant finding is capsular retraction in the right lobe of the liver.
Yeah,
It can be seen in cholangiocarcinoma, confluent hepatic fibrosis, and इतना common नहीं होता, और and in the recurrent pyogenic cholangitis, but it is seen in left lobe more commonly, capsular retraction. And meds
you have
can
told carcinoma and congenital hepatic. What other cause you have told?
RPC can cause, but that will be in the left lobe of the liver, and certain. This is the right lobe, and certain metastasis can cause retraction.
The one which are having desmoplastic component, like the pancreatic ones and the breast ones.
Yeah, can metastasis produce this type of appearance? Yes or no?
Yes, sir.
Yes. So which metastasis can cause these type of
so the ones having desmoplastic component, like the pancreatic and the breast tumors.
Okay. So we'll see this is the intrahepatic cholangiocarcinoma with capsular retraction, and the common causes can be cirrhosis, HCC, hepatic metastasis, hemangioma, hepatic inflammatory pseudotumor. These are all can cause capsular retraction, and these are some mimics. And what is the even tumors, that is fibrous primary tumors such as lung, breast, colon carcinomas and carcinoid. These can cause hepatic capsular retraction. Especially breast carcinomas can cause massive capsular retraction. So this you have to remember. So breast carcinomas can cause massive capsular retraction. So they get 1.5, sir.
1.5 for team 2.
Yeah. Next one, question 3 for team 3. Identify the mark structure and to mention 2 indications where it is used. Second question is name absolute contraindication where it should not be used and serious complication associated with this treatment. So what is this structure?
Marked structure and 2 indications.
Team 3.
Yes, sir. So this is a stent. This is used in.
Name the structure first. Name the structure.
Structure kya hai?
Mark structure means.
What is the tube? The structure means what is the tube? What is that stent, right?
Yeah. Then what is that stent? You should have a name of the stunt, no?
Inguinal canal.
Okay. What are the two indications where it is used? What is the stunt? You did not answer the stunt.
If there is any if there is any stricture or there is malignant compression of the structure, then the stent is used to dilate the structure, and this is probably a GI stent that is used. And if there is,
you are correct, but you are somewhat vague.
Ureter na GI মানে কিছু self-expanding metal stent, but
self-expanding metal stent, that is it should not be used if there is a chance for perforation, like, and the self-expanding metal stents easily migrate out of the place. So serious complication is migration and rupture and perforation of the GI tract.
I'll show the answer and we'll discuss. This is a colonic chew stent. So this is colonic chew stent. This colonic chew stent is a stainless steel cylindrical zigzag stent, which is used in colonic decompression in carcinoma before surgical treatment. And it is also used in dilatation of colonic strictures or colonic diverticulosis. The absolute contraindication is bowel perforation. And the serious complications can be stent migration, stent rupture, obstruction, or perforation. So they have told the answer, sir, but somewhat vague. They did not use the word colonic stent. That is the main thing. When if they use the word colonic stent, then we can. So half and half, sir. 1 mark.
1 mark.
Yeah. 1 out of 4, sir. We have said all the complications.
1 out of 2. 1 out of 2.
Okay, okay.
So this is 2, half and half.
Okay.
False cable.
So this is the colonic chew stent. And this is the diagram which shows the colonic chew stent, how it is inserted.
Yes, sir, we didn't know the exact name. But
yeah, that's what. If you have used the word colonic chew stent, I will definitely given 1.5.
Okay, sir.
Yeah, next question 4. Team 4. Tell me the abnormal findings in this case. In the both images are provided to you.
We can see a hypertensive liver.
Yeah.
With the cardiomegaly. So could be some amiodarone induced amiodarone toxicity. So the
Anything other you describe completely, no? Only cardiomegaly? Can you see any other thing in the lungs?
Bilateral pleural effusion and also
Okay, what is the pathogenesis? What is the cause of this hyperdensity in the liver and the lung? This is also hyperdensity in the lung, no?
Yes, sir.
Yeah, even atelectasis is there, bilateral pleural effusion is there, is cardiomegaly is there, along with hyperdense liver when compared with spleen. This is a non-contrast CT. Huh?
So increased iodine deposition.
Yeah, and we must ask the history in this patient. What is the
drug intake, amiodarone drug intake.
What is to which class it belongs? Amiodarone.
Yes. Calcium.
It's a class 3 antiarrhythmic.
Calcium.
They're right. We can give 2 marks to them, sir. They are iodine toxicity and even pathogenesis is due to iodine content. So this is amiodarone toxicity where you can see the hyperdense liver and also hyperdensities in the lung along with pleural effusions. And it is due to increased iodine content because it comprises 37% of iodine by weight. It's a class 3 antiarrhythmic drug. Toxicity can be seen. This is the dosage we have to remember. So correct, sir. You can give 2 marks to them.
Done, sir. Given, sir.
Yeah. Question 5, team 5.
Sir,
diagnosis and what is Borjat's triad?
So it's a gastric volvulus, sir.
Complete diagnosis. What is the type of gastric volvulus?
It's an antrum or mesenteroaxial. Organoaxial.
Then left is organoaxial only. Yeah. What is Borges triad?
Borges triad is intractable intractable retching without vomiting. First is sudden epigastric pain, and third is inability to pass nasogastric tube.
Yeah, that is correct. What is cascade stomach? Why it has to be differentiated from this entity?
So in cascade stomach, basically no volvulus is there actually. It's just the rotation of the mesentery, and we need to differentiate because it's a organ axle is a MNC.
No, you did not mention correctly about cascade stomach. You can give 1.5, sir.
Okay, 1.5 marks.
So this is Borges triad is nothing but this is an organoaxial gastric volvulus with hiatus hernia. This is cascade stomach. So Borges triad is severe sudden epigastric pain, intractable retching without vomiting, unable to pass a nasogastric tube. Cascade stomach is a congenital variant where the greater curvature will be drawn superiorly than the lesser curvature. So you can see this is the greater curvature is above and the lesser curvature is below. So the contrast fills the lesser curvature first, latter followed by the greater curvature, which typically mimics the gastric volvulus. But it is a congenital variant. It should not be operated. Whereas gastric volvulus is a surgical emergency. It has to be operated. That is the difference. That is the reason we have to differentiate gastric volvulus from cascade stomach. Next question 6 for team 6. There are two cases which are given. One A and the other one is B. So you have to diagnose both. What is the diagnosis along with imaging findings, and what are the diagnosis along with imaging findings? That these are two different cases, A and B.
What is this? Contrast on the leaf, two mixing hypodense or hyperdense content. Tell something.
Looks are not dilated. Colon is here. There are mass, there is no mass. Mass it is
Getting over.
Describe it and give the diagnosis. Time is over.
Second case is having some two densities noted within this.
Lymphatic malformation.
And there is a bubble wall thickening in this.
Yeah, exam spotter.
Both are exam spotters. Classic exam spotters.
0 marks, sir.
0 marks. 0 marks. Yeah, so you can see this is nothing but you can see extensive retroperitoneal, mesenteric, and even pelvic. There are multiple low attenuation lymph nodes with central necrosis. Even there is free fluid and even some matting of the bowel loops. So this is classical tubercular lymphadenitis. So this is a classical case of tubercular lymphadenitis with necrotic lymph nodes. So that is low attenuating lymph nodes. Here you can see these are multiple lymph nodes. They are showing fat fluid levels. So fat is above, lighter, so it is above, and fluid level. So this fat fluid levels is called as cavitating mesenteric lymph node syndrome in celiac disease. So it is characterized by triad of splenic atrophy, low attenuation lymphadenopathy containing fat fluid levels, and villous atrophy. So the first case is tubercular peritoneal lymphadenitis. Second one is cavitating mesenteric lymph node syndrome in celiac disease. 0 marks, sir.
Okay, sir.
Then question 7 to team 7. These are also two different cases. This is one case on the A on the right and one case on the B on the left. So two different cases. What is the imaging findings and diagnosis in A, and what are the imaging findings and diagnosis in B? Both are also classic spotters. Team 7.
These abscess.
Yeah.
Continuously hyperdense lesion with peripheral
With clustering
enhancement
sign.
and clustering.
You're telling about B or A?
B, sir.
B. So this is your describe it.
Option A, is it a particular teratoma, because you can see a calcific foci and some fat attenuation.
Wrong answer. A is wrong.
Hydrated.
Then go for B at least.
Hydrated, could it be a possibility?
B. What is your answer for B? One is wrong.
This B is very classical.
B abscess.
B abscess.
Then there are lots of abscesses, no?
Yes, sir.
Specific.
There is multiple clustering, peripherally
Pyogenic.
enhancing hypotenuse areas.
Pyogenic.
Yeah. We can give 1 mark for B, sir.
For team 7.
1 mark. This A is, remember, this is also abscess, this is also abscess. Both are abscesses only. But in A, you can see there is layering pattern and central calcification. This central calcification in the abscess, if you see, definitely suspect brucellar abscess. Okay. So whenever you see an abscess with layering pattern and also hyperdense layering pattern and central calcification, which is the most clinching factor, so that is the case, you have to suspect brucellar abscess. And here you can see this is a rim sign that you can see central enhancement and peripheral hypodense rim. And also you can see cluster of abscesses. This is pyogenic liver abscess. So this is brucellar abscess, this is pyogenic liver abscess. So this is double target cell and cluster sign in pyogenic liver abscess. And brucellar abscess, central calcification. You can see liver abscess with calcification 77% in case of brucellar abscess. This you have to remember for this case. Next question, YITE for team YITE. Question YITE.
Multiple cystic lesions are there.
What is the best diagnosis? What is the best imaging modality? And what is the differential diagnosis and how to differentiate this entity from that?
पैनक्रियाटिक सिस्ट आ रही है और कुछ आ रहा है किडनी वगैरह में
See all the images. These are CT images and these are MR images and this is the MR CT image.
Multiple cyst. Kidney का है
नहीं दिख रही वो सेक्शन नहीं है multiple. So there are multiple cystic lesions in the pancreas.
Yeah.
And
right kidney, there are multiple cysts also there in the right kidney. And
no, it is superimposed. They are not in the kidney. They're in the pancreas only. It's a superimposition of the pancreatic cysts over the right kidney. Small cysts are there, but they are not significant in the kidney. In the left kidney, you can see tiny cysts.
Multiple variable size cysts in the pancreas and
okay, time up. Yeah. So these are nothing but intraductal pancreatic mucinous neoplasms or IPMN. You can see multiple cysts noted in the even in the body and tail of the pancreas, in the head of the pancreas. They are communicating with the main pancreatic duct and also in the side branches. So MRCP is the best sequence to differentiate intraductal papillary mucinous tumors from the mucinous cysternoma or cysternocastoma, because this IPMN will communicate with the pancreatic ducts, whereas mucinous cysternoma or cysternocastoma do not communicate with the pancreatic ducts.
How many marks?
No, half mark we can give for description at least.
5 marks for the description.
Yeah, but diagnosis they did not arrive at the diagnosis, and they what is the differential also they did not tell us.
Everybody should know.
Yeah. So this is a classical image you can remember. Whole of the pancreatic duct is replaced and also multiple cysts are communicating with the pancreatic duct. That's why MRCP is the best modality. Next, question 9. Question 9 for team 9. This is also a classical case.
Yes, sir.
What is the lesion and what is the criteria used on CT to diagnose this entity? Which modality best differentiates this entity from its malignant counterpart and how?
So this is a case of mesenteric paniculitis.
Sir, there is diffuse fat stranding in mesenteric region, in mesentery in umbilical region.
Yeah.
So on the basis of my findings, likely it could be mesenteric paniculitis.
But my question is, which criteria used to CT diagnose this entity? I am not able, did not ask to diagnose it. I told what is the criteria name used on CT to diagnose this entity. Do you know any criteria which is used to diagnose sclerosing mesenteritis or mesenteric paniculitis? And which modality best differentiate this entity from malignant counterpart and how?
Sir, PET CT, on PET CT we can differentiate it from its counterpart.
Yeah. So half and we can give it, sir, 1 mark.
The uptake will be there if FDG uptake will be there if there is malignancy is there.
The criteria you did not tell. If you have told, I would have given 1 mark. So half and half, sir, 1 mark.
Total 1 mark, yes.
Question 9, 1 mark. Team 9, 1 mark. So this is called as Collier criteria. You remember this Collier criteria? where you can see there are mass effect over the adjacent neighboring structures. This is an inhomogeneous high density fat, which is more density will be more than the adjacent mesenteric fat. There will be small soft tissue nodules, and also you can see that fat halo sign, and this is in turn surrounded by the hyperrotating pseudocapsule. So these fat halo sign and hyperrotating pseudocapsule are the most very specific for this diagnosis of sclerosing mesenteritis. And FDG PET, this sclerosing mesenteritis is not FDG avid, whereas malignant mesenteric involvement is nothing but FDG avid. So FDG PET helps in differentiating both these entities. So 1 mark for them.
1 mark.
Yeah. Question 10. Team 10.
So the diagnosis specific history we asked to prevent this complication. Sir, gossipaboma.
Correct. Gossipaboma is correct answer. What is the
Specific
specific
history of surgery, sir?
Yeah, and how to prevent this complication?
Sir, correct counting before and after surgery.
What we should count?
The number of gauge pieces, sir. Utilized gauge pieces.
Swabs. So, and which tumor can develop in this type of complication? Do you know any
tumor? Semifinal. Polypoid textuloma ये सब उसको बोलते हैं, but उसका ट्यूमर कौन सकता है?
If you know it, tell it. You can't guess it. Yeah. So gossipaboma is 1 mark, sir. Correct answer. But the tumor they did not tell. So 1 mark for them.
Total 1 mark.
Yeah, because
Angiosarcoma, sir. Angiosarcoma.
Yeah. Correct. Angiosarcoma is the correct answer, sir. So you can give 2 marks to them.
2 marks. Great.
Excellent. Very good. Yeah. So this is gossipaboma. We had to ask previous history of surgery, and theater swab count should be definitely counted, and they should match before and after closing the abdomen. And infrequent reported possible complications of retained surgical sponge is angiosarcoma. You remember angiosarcoma. Next question 11 for the team 11.
Yes, sir.
The 35-year-old male came with the complaints of headache, seizures, hearing, visual disturbances with severe abdominal pain. What is the most probable diagnosis and imaging findings? What other screening is required to confirm the diagnosis? What is the most common cause of death in this type of patient?
Sir, multiple cystic lesions are seen all along the pancreas and also in the kidney, sir. And there is a lesion which is showing fat separation. Could be Von Hippel-Lindau, sir.
Yeah, Von Hippel-Lindau is the correct answer. And what other screening is required to confirm this diagnosis?
We have to do brain with spine screening. We have to do, sir.
For what?
To detect hemangioblastoma and other lesions which we see in VHL, sir. Also, optic screening is needed.
Spine. Why you should screen the spine?
Spine also we can get hemangioblastoma, sir.
Along with the drop metastasis.
Drop metastasis.
Drop metastasis is the most important part we have to remember in case of hemangioblastoma. What is the most common cause of death in these type of patients?
AML going for complications, sir. Kidneys.
What is the common cause of death in these type of patients?
Renal cause, sir. Like renal complications secondary to AML.
You can give 1 mark to them, sir. They are told half we can give renal, but they did not tell the correct answer, no, sir.
Yeah, renal failure.
Renal failure causing to
1 mark.
1 mark. 1 mark. So what is the most? So this is nothing but Von Hippel-Lindau disease, and also we have to screen the brain and spine for hemangioblastomas and also drop metastasis. Renal cell carcinoma, specifically of the clear cell subtype, is the most common cause of death, occurring in 70% of effective individuals by age of 60 years, and is the leading cause of death in VHL. So remember, renal cell carcinoma, specifically of the clear cell subtype, is the leading cause of death in VHL. 1 mark, sir.
1 mark, done.
Question 12. Question team 12 for team 12. Young adult came with complaints of poor appetite, poor weight gain, recurrent cough, respiratory infections, recurrent onset of abdominal pain, now presented with abdominal distension and vomitings. What is the most probable diagnosis based on imaging findings? What is the diagnosis? What are the imaging findings and diagnosis?
Abdominal distension and vomiting. Dilated recurrent cough, respiratory lymphangiectasia. There is some appearance lesion. Okay? Just a right open ball, you can get to some. SMS syndrome है कुछ है क्या? नहीं,
Fast.
it's getting SMA. Lymphangiectasis.
You don't have much time.
Lymphangiectasis.
Wrong answer. What is the pathology of genetic defect? Can you guess in this case?
Yes.
Because the diagnosis is only wrong, we can't guess it.
Genetic defect causes a disease in Western children. Cystic fibrosis.
Yeah, tell why? You have told lymphangiectasia and cystic fibrosis. Those are all.
इसमें कुछ obstruction दिख रहा है और कुछ तो दिख नहीं रहा है. Bowel obstruction.
Time up, sir?
Yes, sir.
Yeah, we can give half marks, sir. At least they have guessed cystic fibrosis, so half mark.
This from my history.
So you can see the whole of the pancreas. Can you see the pancreas here? What will be the structure here? Pancreas. Pancreas is completely replaced by fat. So there is pancreatic lipomatosis, and also you can see the small bowel, multiple loops of small bowel which are dilated, and there is also hyperdensity within the bowel. So this is nothing but called as distal intestinal obstruction syndrome, or DIOS, formerly known as mecanomelia, which is classically seen in case of cystic fibrosis. Pancreatic lipomatosis we already seen, and cystic fibrosis is due to homozygous defects of CFTR gene located on chromosome 7. And this is only conservative treatment should be used, like adequate hydration, even water soluble gastrography in contrast enema, and intestinal lavage. We should not go for any surgeries in this case. So this is distal intestinal obstruction syndrome in cystic fibrosis. Sir, we have completed GIT now, sir. 12.
Go to GOT now. Again, team 1, please be ready.
Yeah, team, we are going to the GUT now, team 1. So question 1, what is the best possible diagnosis and what is the criteria used to diagnose this entity? Team 1.
You are there, team 1?
Yes, sir. Accessory cavitating uterine mass now.
Yeah.
Accessory cavitating uterine mass.
Yeah, what is the criteria used to diagnose this entity? The diagnosis is perfect. So what is the criteria used to diagnose this entity? There are 4 points in it. You should tell all the 4 points. Then only you will get the 1 mark. Because sometimes endometriosis can also look like this. Sometimes even unicornate uterus also can look like this. So why you have to differentiate ACUM from these entities? And what are the points in favor of ACUM you should know? Do you know or not?
We can pass.
Yeah. So 1 mark we can give it, sir. ACUM, the diagnosis is correct. So accessory and cavitatory uterine mass, because there should be accessory cavitatory mass along the uterine wall under the round ligament, not communicating with the main uterine cavity. So in this case, you can see this is not communicating with the endometrium or uterine cavity. Normal uterus, fallopian tubes, and ovaries should be there. Blood degradation products in the cavity or cystic part can be there. No adenomyosis in the main uterus should be there. So there should not be any other adenomyosis features in the uterus. So these are the 4 points which helps in diagnosing ACUM, that is accessory cavitatory uterine mass. 1 mark, sir.
1 mark, yes.
Next, question 2.
Team 2.
Team 2, question
Yes,
2.
sir.
So you can see there are 2 images here. So this is a case of pelvis, this is a case of brain. So you have to correlate both the images and come to a
नहीं होता है वो जो उसका होता है एंकेफेलाइटिस होता है उसका साइड इफेक्ट योग सेक्टिंग होता है ऑटोमेटिक कोलेट है
So what is the diagnosis?
There's a T2 heterogeneously hyperintense lesion in the likely arising from the cervix.
Yeah.
And
and it is causing
so this is a paraneoplastic
hydroureter, the left ureter is dilated.
Also, there is suggestion of paraneoplastic syndrome. the encephalitis in the brain.
Only on diffusion we can't diagnose encephalitis, no. So there should be other sequences to diagnose encephalitis. This is the only one sequence I have kept. Specific reason is also there. So can you club these features? You can see this is definitely a cervical malignancy. Yeah, which is called infiltration into the ureter. So there is left-sided hydroretor nephrosis, and there are multiple infarcts. So anything diagnosed, you know, when you club both these features. And what is the sign?
Name of sir.
Yeah. Tie up, sir.
Yes, sir.
Yeah. We can give half marks at least for the description, sir.
Okay. 0.5.
0.5. So this is nothing but 3 territory sign. This 3 territory sign is nothing but bilateral anterior and posterior circulatory infarcts is a 3 territory sign. It's a radiological marker of malignancy related ischemic stroke that is called Trausis syndrome. So in this case, you can see there is a cervical malignancy, and also you can see there are infarcts in the bilateral anterior territory and also in the cerebellum, that is posterior territory. So there is 3 territory sign in case of malignancy related ischemic stroke. And what are the malignancies which can cause 3 territory sign? That is lung, gastric, colorectal, gynecological, hepatic, and prostate carcinomas can cause this 3 territory sign. And of these, lung carcinoma is the most frequently associated with malignant related ischemic stroke. So whenever both the images are kept, definitely remember 3 territory sign in case of malignant ischemic related stroke. And lung is the most common primary which can produce malignant related ischemic stroke. Next question 3, 35 of 14.3.
Yes, sir.
Yeah, 35 a female with chronic pelvic pain. So what is the diagnosis? What is the most common differential diagnosis? What is the serious complication associated with this diagnosis?
So there is multiple cystic lesion noted in the periphery of the uterus. The lesions looks like there is the cystic lesions look like there is some amount of bleeding component, like shedding is there. So it can be, it doesn't look like, it can be endometriosis, endosalpingosis, something like that, endosalpingosis or endosalpingosis. There is
looks like
specific, whether it's endometriosis or endosalpingosis.
It is more towards endosalpingosis because it is kind of cystic.
Endosalpingosis is the correct one. And what is the differential diagnosis?
Endometriosis.
What is the serious complication associated with this diagnosis? When you see this endosalpingosis, what is the serious complication associated with this diagnosis?
Malignancy.
What type of malignancy?
CA, serous ovarian, serous.
Yeah, excellent. Correct one, answer. So they have told endosalpingosis and also serous carcinoma.
2 out of.
Yeah,
Very
2 out of 2. Excellent. So this is endosalpingosis, where there is the ciliated glandular epithelium resembling internal lining of the fallopian tube, located in ectopic location, like in the surface of the uterus or ovaries or in the pouch of Douglas and the pelvis. Most common differential is cystic endometriosis, but in cystic endometriosis, hemorrhage can be seen and shading sign can be seen. And what is the serious complication is, this is endosalpingosis is considered a part of spectrum of peritoneal serous lesions. So borderline and low grade ovarian serous neoplasms is the complication which can develop in endosalpingosis, that we have to remember in this case. 2 marks, sir.
Given, sir. 2 marks.
Yeah, question 4. What are the abnormal findings and most probable diagnosis? So question 4 for team 4. This is also a classical case. What are the abnormal imaging findings? Images are there. This is the IVP image. This is also IVP image. This is also IVP image.
Infantibular stings. IBP image is showing brush border sign indicating of medullary small kidney, and there is
This one is what is this appearance called? Classical appearance.
Striate.
What is the diagnosis you are told?
It's medullary sponge kidney.
Yeah, correct. What is this imaging finding?
Paintbrush.
Yeah, paintbrush appearance. This appearance is called?
Bouquet, flower bouquet appearance.
Bouquet of flowers.
Bouquet of flowers.
Bouquet of flowers appearance. And this one is called? This one and this one. Yeah. Name two syndromes associated with this diagnosis.
Diamond black Fanconi syndrome.
Wrong. You can give 1 mark to them, sir. Syndromes they did not answer. Yeah.
1 mark.
Yeah. So this is nothing but classical bouquet of flowers appearance. You can see this is a bouquet of flower appearance. This is paintbrush appearance, and this is growing calculus sign. So these three are classical features of medullary sponge kidney. Name two syndromes are nothing but Ehlers-Danlos syndrome and congenital hemihypertrophy, that is Beckwith-Widman syndrome, are associated with medullary sponge kidney. 1 mark, sir.
1 mark, 1 mark.
Question 5 for team 5. There are two images shown here. One is on the A, other one is on the B. So you have to diagnose both. So what is the diagnosis in A and what is the diagnosis in B?
So one is I think RGU-MCU study, sir. There is multiple diverticular noted in the anterior urethra, sir, and also there is extra vessation of there is a urethral rupture.
You are telling about B.
B is urethral rupture, sir. Also there is a multiple diverticular seen, sir. Multiple odd pouching. Odd pouching can be seen, sir. It appears to be beaded and dilated. And
what is the diagnosis then?
Chlamydial urethritis with urethral rupture.
Rupture is there. That's in contrast to it.
Yeah. Then A.
There are multiple punctate calcifications also seen, likely the prostatic calcification, and narrowing of the prostatic urethra and bulbar urethra is seen, sir. Prostatite.
Time up, sir.
Likely membranous urethral injury, sir. Post-traumatic.
We can give half.
There's a fracture. There's a fracture of pelvic fracture is also there, sir.
With urethral injury.
Don't speak more, you will lose that also.
Okay, sure.
Okay. So these are nothing but you can see multiple seed-like structures now in the prostate, especially in the prostate. So these are nothing but brachytherapy seeds implanted in the prostate, and you can see there is a narrowing or stricture of the prostatic urethra. So this is post-radiotherapy or post-brachytherapy induced stricture of the prostatic urethra. These seeds are nothing but multiple brachytherapy seeds implanted in the prostate. Here you can see there is irregular beading and narrowing of the bulbar urethra. These are nothing but Litter's glands. These are normal opacification of the Litter's glands. These are multiple stricture beading, narrowing of the bulbar urethra. This is periurethral abscess. So you can see there is a large communication between the abscess in the periurethral region arising from the ventral aspect of the bulbar urethra. So we can give half marks, sir. Half and half, at least one.
1 mark, 1 mark for them. Okay.
You have described the findings.
Okay.
These are not prostatic calcification. These are brachytherapy seeds. Okay.
1 mark for team 5.
Yeah. Then question 6, sir. Question 6 for team 6. Team 6, are you ready?
Yes, sir.
Yeah.
Horseshoe kidney.
The question is, which anatomical structure is the culprit in the pathogenesis of this anomaly and serious or lethal complication associated with this diagnosis?
Embryologically, it will inferior mesenteric artery will stop the ascent of the kidneys.
That's correct. That is inferior mesenteric artery around the level of isthmus at the level of L3 will prevent the ascent of the kidney, leading to horseshoe kidney. What is the serious or lethal complication associated with this horseshoe kidney?
During surgery,
there can be injury to the isthmus.
That is not. What any other complications like things? Serious and lethal complications associated with this diagnosis?
horseshoe kidneys are usually associated with mostly they will have more prone to caliculi formation and
lethal complication.
Serious.
Malignancies.
What type of malignancies?
Renal cell carcinoma.
Transitional cell carcinoma.
Yeah, transitional cell carcinoma of the pelvis is the most common diagnosis we have to suspect, and it's a serious complication. And one mark, what is sigmoid kidney? You know horseshoe kidney, no? What is sigmoid kidney?
If the kidneys are on same side, ipsilateral side, and they cross fuse with each other.
Cross-fused renal ectopia.
Wrong. 1 mark, sir. 1 mark for complete 1 mark for the first question, and sigmoid kidney is the wrong answer, sir. So here you can see horseshoe kidney ascent is nothing but restricted by the inferior artery which hooks around the isthmus at the level of L3. Williams tumor, transitional cell carcinoma of the renal pelvis, and renal carcinoma of the malignancies which can occur in lethal complications in horseshoe kidney. Horseshoe kidney where only the inferior poles are fused, but in sigmoid kidney both the upper and lower poles are fused. So that is the differentiation we have to remember as a counterpart of horseshoe kidney. So if only the inferior poles are fused, it's a horseshoe kidney. If both the superior and inferior poles are fused, it's a sigmoid kidney. 1 mark, sir.
Okay, done.
Yeah. Question 7 for team 7. You see, the 26-year female, chronic lower abdominal pain since 6 months, complaints of hirsutism, no fever, no vaginal discharge, no history of PCOD. What is the most probable diagnosis based on imaging features? What is the common differential for this? And how to differentiate this entity? Team 7.
Peritoneal.
Team 7. See all the images. This is ultrasound image. These are MR images. This is also MR-T1. This is GRE. This is post-contrast T1 FS. See all the images and come to a conclusion.
So we can see a
Cystic
cystic
lesions.
lesion arising from the right adnexa.
Yeah, be specific. Right adnexia, more than right adnexia.
Probably arising from right ovary. You can't see the right ovary separately from the
right ovary because right ovary is not separately seen apart from this mass lesion.
It's something secretory tumor, mostly some germ cell tumor.
Wrong answer.
So epithelial tumors like serous cystadenomas.
Androgen.
Writing time up.
Peritoneal inclusion.
Time up, sir. Time up. So you are thinking it as a tumor, no? So then the
right ovarian tumor.
So this is nothing but called as massive ovarian edema. So you can see this ovary is enlarged, the follicles are enlarged, and also you can see there is right ovary is completely enlarged compared to the left. And also you can see on T1 there is no hyperintense areas on T1. There is no blooming on GRE. And also you can see there is enhancement. Even normal ovarian enhancement is there, but there is hyperthecosis. And also there is dominant follicles are there and peripheral enhancement. There is no abnormal enhancement in the ovary. So this condition is called massive ovarian edema, which commonly mimics ovarian torsion. So in this is not a case of torsion because we are able to see the normal enhancement of the ovary and also there is peripheral enhancement over the ovary. It is due to intermittent or partial torsion of the ovary, compromising the venous and lymphatic drainage, but with preserved arterial supply. It is also associated with elevated androgen. That's why in this case we have hirsutism in this case. And most common associated with mixed syndrome or precocious puberty. Most common differential will be ovarian torsion. In this, you can see this is the ovarian torsion. Whole of the ovary is enlarged, but there is no enhancement in the ovary, and there is twisted pedicular vascular pedicular side. But here there is no twisted pedicular vascular pedicular side. So massive ovarian edema is one entity, benign entity you should remember. And most common difference is ovarian torsion, oophorytis, ovarian fibromatosis, and even hyperstimulated ovaries.
0 mark.
Yeah. This is also other case where you can see this is completely blooming on GR. This is the ovarian torsion case. Typically peripheral placed follicles, and also you can see this blooming on GRE and no enhancement on IV contrast with twisted or vascular pedicle sign. This question 8 for team 8, there are two cases. One is A and the one is B. You have to diagnose both. Question 8 for team 8. You can see this is a neonate presenting with sepsis. B is neonate presenting with hypotension and electrolyte imbalance. So what is the classical imaging features and diagnosis? What is A? What is B?
Sir, on image B, we can see there is diffuse enlargement of the suprarenal gland. Combined with electrolyte imbalance, it could be due to congenital adrenal hyperplasia.
Very good. So what is the classical imaging appearance we have to suspect?
Sir, the Y-shaped appearance, inverted.
Normally the tunnel will be Y-shaped or bifurcated. Any specific imaging pattern or specific imaging appearance in the adrenal by which we can suspect congenital adrenal hyperplasia?
Hypoechoic.
And sir, in image B, there is hyperechoic contents within the lesion with thick hyperechoic walls. It could be adrenal abscess.
So this one is congenital adrenal hyperplasia. Okay. So you do not tell the classical appearance on this one. What is the diagnosis in A?
Sir, A is abscess, adrenal abscess.
More common than abscess. In a neonate, abscess will be very rare.
Here's Delhi. Sir, hematoma.
Yeah.
Adrenal hematoma. And classical B, cerebriform appearance B.
Yeah. You can give 2 marks, sir.
2 marks.
So this is a neonatal sepsis where you can see neonatal adrenal hemorrhage, but there is neonatal adrenal hemorrhage, and this one is nothing but enlarged adrenal gland. I have not given as ambiguous genitalia. If I have given as ambiguous genitalia, definitely everybody will diagnose it as congenital adrenal hyperplasia. So that's why I have given symptoms of Salk-Pasting syndrome. And this classical imaging appearance is cerebriform pattern of appearance. Can you tell me other cerebriform appearance, Team 8? Any other cerebriform appearance you know? It's tumors. That is solitary plasmacytoma will cause a pattern that is solitary brain appearance, and also inverted papilloma will have cerebriform
in the spine.
These 3 cerebriform patterns you should remember in your exams. So one is cerebriform pattern of adrenals in congenital adrenal hyperplasia. Other one is solitary plasmacytoma which gives mini brain appearance, and other one is cerebriform type of enhancement in inverted papillomas. Yeah. Correct, sir. 2 marks, sir.
2 marks. 2 marks. Give us.
Question 9 for team 9. So what is the surgical procedure done here? What are the common indications for this procedure? And what are the common
reimplantation? No. Sir, there is reimplantation of ureter done. Left ureter is done. Likely post ureterocele, Conan's reimplantation, name of procedure.
See again whether it's a ureter or something else.
Bladder.
What you are told is absolutely wrong answer.
Sir, bladder dome of the bladder is connected to the. We are creating a new track for the passage of urine.
Yeah, then what is the surgical procedure? There is a specific name for this procedure where it is done.
Sir, bowel is attached ileum.
No, wrong. What are the indications of this procedure? You did not answer the procedure, but what is the indications of this procedure? And complications of this procedure?
Sir, CA bladder, bladder carcinoma or distal ureteric carcinoma.
Okay, complications?
Sir, complication could be infective complication. There could be urine leak, could be there, or recurrent UTI could be there. Formation of urinoma can be there.
Yeah, 1 mark we can give it, sir. Surgical procedure did not mention.
Sir, Cohen's reimplantation.
So leave it. This is a psoas history. So where you can see the bladder is typically elevated above and it is stitched to the left psoas muscle, so that the distance between the ureter stricture, which is due to malignancy, can be decreased, and also uretrix can be reimplanted in the bladder. So this is psoas procedure, and also bladder is pulled up and secured to psoas muscle to reduce the distance between distal ureter and bladder, and that is ureteroneocystostomy. Urinary leak, strictures, and vascular compromise is the most important complication you have to remember in this case. This is a psoas procedure. Yeah. Okay. Other one is Bori flap. Bori flap is nothing but the tubular recanalization of the ureter is done. So Bori flap and psoas which are commonly done in bladder malignancies or ureteric malignancies or stricture due to carcinomas. 1 mark we can give it, sir.
1 mark for team 9.
For second question they are given it. Next question 10 for team 10.
The diagnosis.
So what is the classical diagnosis? To which class of Muller and duct anomaly it fits in? Mention to pathological condition where it is seen.
T-shape.
Yeah, T-shape uterus.
T-shaped uterus, DES exposure.
No, what is the Muller induct anomaly? Where it fits in? Classify it.
Type 7. Type 7 is
Yeah, correct.
type
So
7.
T-shaped uterus and class 7 you have given. Mention two pathological conditions.
Sir,
which-
exposure of DES in utero.
Yeah.
Second one, DES in utero. Okay. और किसी में होता है? Sir, in case of premature labor,
No.
premature
Yeah.
DS exposure and cervical stage.
Sir, we can give 1.5, sir.
1.5 marks.
Yeah. So this is nothing but T-shaped uterus, and this is Mullerian duct anomaly class 7.
OCP.
Diethyl exposure seen in 31% of exposed women. Adult women with severe estrogen deficiencies. So adult women with severe estrogen deficiencies and chronic OCP pills can also cause T-shaped uterus. These three you remember. Okay, at least this will be a common, everybody will remember. But apart from that, severe estrogen deficiencies, adult women and chronic OCP pills can also cause T-shaped uterus. Question 11 for team 11. So what is the diagnosis and what are the characteristic imaging findings which helps in the diagnosis? What is the differential diagnosis?
This is a cystic neoplasm from the left kidney, sir. Diagnosis is MC. No. The extension into the pelvis is the imaging finding which helps in the diagnosis. Extension into the renal pelvis.
More specific word than extension?
Like
Use a specific word. Extension is not a specific word for the diagnosis. What is the diagnosis? You are told it's extending into the renal pelvis. So what is the diagnosis then?
cystic neoplasm differential. Sir.
So what is the differential diagnosis? At least you are not able to tell the diagnosis. What are the differential diagnosis for this entity? Is it benign or malignant, this one?
Malignant neoplasm. Sir.
Then what are the other differential diagnoses for this case?
Mesenchymal. Mesenchymal neoplasms in pediatric patients can also have a multicystic appearance.
Half mark we can give, sir. They have told classical extension into the renal pelvis, but diagnosis they did not tell correctly. And also differential diagnosis. So this is nothing but multilocular cystic nephroma. That is the word you should use. So multilocular cystic nephroma is nothing but it will have well-defined margins. There will be enhancing septa and herniation into the renal collecting system. You have used extension into the renal collecting system. Any tumor can extend into the renal collecting system, but herniation of the cystic lesion into the renal collecting system is the specific point which helps in diagnosing multilocular cystic nephroma. And also cystic nephroma is indistinct from multilocular cystic renal neoplasm of low malignant potential, formerly called as multicystic RCC. So multicystic RCC is the most common differential for this multilocular cystic nephroma and also herniation into the renal collecting system. Half mark we can give it, sir.
Given, sir, half marks.
Next, question 12. Last question. Question 12 for team 12. You can see this is the most film. What are the abnormal imaging findings? Mention two causes for each imaging finding. There are two imaging findings in this.
Persistent dense nephrogram and lead pipe colon. Pneumatosis.
Yeah, this one is
Persistent dense nephrogram.
okay. This one is
Pneumatosis coli.
Pneumatosis intestinalis or pneumatosis coli. So imaging findings are correct. Mention two causes for each. Two causes for persistent nephrogram.
In critically ill patients like ARDS, persistent dense nephrogram तो AKI में
No, there is a specific history. In that case only you will get persistent dense nephrogram.
Nematocyst intestinal.
At least tell the causes for nematocyst intestinal. It's very easy. Two causes. Two causes where you get yeah, ischemia.
Bowel ischemia.
Then other one. Common.
Most common exam questions.
These are stocks, sir. Stock.
They are tired. Everybody is tired now.
From I think from 8:30 to 11:30, sir.
Renal vein thrombosis.
Yeah, correct. So we can give 1.5, sir.
1.5 marks.
Yeah. So persistent dense nephrogram, most common cause is systemic hypotension. So systemic hypotension is the feature for persistent nephrogram, and also it is called as CT hyperperfusion complex. It can be also seen in acute tubular necrosis, renal artery or vein thrombosis. And nematocyst intestinalis, that is also seen in low flow states, that is hypotension or congestive heart failure. So this was a patient who went into congestive heart failure and hypotension followed by IVP. That's why there is a persistent dense nephrogram and also nematocyst intestinalis in the same case. And even other arterial occlusion, atherosclerosis or emboli, venous thrombosis, hypercoagulable states and OC pills can also cause this appearance. Yeah, sir. So we have completed all the 12 of GIT and 12 of GUT, sir.
Great. I'll just quickly tell the scores. So there are top 3 teams now, each with 11.5 marks. One is team 3, then it is team 8, and then team 10. Then 2 teams at the second place, that is team 1 and team 2. And then I'll just read out rest of the scores. Team 4 is 8.5 marks. Team 5 is 10.5 marks. Team 6 is 8 marks. Team 7 is 6.5 marks. Team 9, 7.5 marks. Team 11, 7.5 marks. And Team 12, 7.5 marks. Thank you so much, sir.
Thank you, sir, for giving this opportunity. I hope I have given some good cases with clinically relevant diagnosis. Yeah. Thank you, IRIA, for giving me this opportunity, and good luck for all the teams. Yeah. Thank you all.
So as it happens in all our emergency duties, an IR case will come right in the middle of night when you are most tired after completing your diagnostic things. So now at last we are going to have the IR cases. Sir, if you could just...
Yeah. Thank you, sir.
And our IR cases actually were given by respected Dr. Pankaj Sharma, sir. But sadly he could not be present, but what I have is his PPT. So what I will do is I will share the PPT, and then we can just take up the cases with everybody. Just 1 second, I'll open the PPT first. Okay, wait a second, just 1 second. Okay, I'll share my screen, and team 1, please be ready. Okay, so team 1, your question is, what is the most common type and bronchial artery branching pattern according to Cordwell's classification?
1 on right, 2 on left.
1 bronchial artery. Sorry, can you repeat it?
1 on right side, 2 on left side.
Sorry, that's the wrong answer. The 2 bronchial artery on left and 1 ICBT on right. That is the most common type of bronchial artery branching pattern. So what is the, can you tell me the type number? What is the type number?
It's the type 1.
Type 1. Okay. So half marks for your answer. And then just 1 second. Huh? Okay. Then question 2 for team 2. Openings of bular collaterals is seen in the disease affecting which artery?
SMA, celiac.
No, you have to give me one answer.
SMA.
Wrong answer. It's celiac. Question 3 for team 3. Identify the person. Full name, please.
Any hint? Seldinger?
Full name.
So telling it.
Seldinger.
Sorry, you'll get 0.5 marks for this. The correct answer is Sven Ivar Seldinger. 0.5 marks for team 3. Team 4. What is the correct etiology for the appearance of the popliteal artery?
Fibromuscular dysplasia.
Huh? Wrong answer. It is stem waves. Team 5. What is the indication for the procedure demonstrated on these images?
Procedure. Sir, MapQuest to MapQuest level.
Indication of the procedure. Do you know the answer?
There is a staples noted in the
What is the procedure, boss?
procedure is pick line.
Sir, 0 marks. Lymphangiogram with thoracic duct embolization for thoracic duct injury. Question 6 for team 6. 48-year-old female taking oral contraceptive pills presents with vague abdominal pain and ascites. What is the most likely diagnosis?
Claude rupture of angiomyolite.
Is that your final answer? Okay, you get 0 marks. It's Budd-Chiari syndrome. Now, next question for team 7. Identify the procedure.
Left internal iliac artery coiling.
Wrong answer. Varicocele embolization. For team 8, most common embolizing agent used in traumatic solid organ injury.
Gel foam.
Okay, you get 1 full mark. Gel foam. Next question for team 9, which is the following is preferred embolic. So, which is the preferred embolic agent for treatment of PAVM? You just have to give me the answer.
Sir, mixture of DMSO and squid.
Wrong answer, it's coils. Question for team 10. Which of the following is an appropriate indication for embolization of the selected vessel?
PPH.
Young age female.
You try PPH. Postpartum hemorrhage.
No, uterine artery embolization for fibroids. So you get half marks. Actually, you identified uterine artery embolization correctly. Next question for team 11. Identify the procedure.
இதுதானே ஸ்பினல் ஏதாவது சொல்லிட்டேன்
Balloon assisted.
Barto, sir?
Barto.
Very good. Quick answer. Barto. Next question for team 12. What variant anatomy is demonstrated on this image? Do you know the answer?
Accessory left hepatic artery. Okay.
Wrong answer. Left hepatic artery arising from the left gastric artery. 0 marks.
नहीं तो बोला था. What's the answer?
What is the variant anatomy?
What's the answer? Sir, we told left hepatic artery arising from
You
left
are
gastric.
accessory hepatic artery. That's it. You have to give the complete answer. Okay. With this, we come to the next question. And I have the results with me.
So Gaurang, I think you should give certificate of appreciation to all the 12 teams.
Yes,
attending, being part of this marathon quiz.
And we should for ourselves sitting till quarter to 12, everybody, and giving
exactly. And everyone did very well. So irrespective of the results, they deserve a lot of appreciation. And to
Absolutely.
reach to this stage also.
Absolutely. And the difference is actually 0.5 marks.
So we have clear top 5.
So I will tell you the rankings, and please identify. All of you can unmute yourself first, and please identify yourselves with your college names as I tell the order of ranking. Okay, because we are on YouTube live right now. So the first is Team 8 with a score of 12.5.
Team 8 is from which place?
Sir, GB Pant Hospital, New Delhi.
Okay,
Congratulations.
You made it to the finals.
Thank you, sir.
In the second place, there are two people, so we can say it's second and third. One is team number 3. Can you identify yourself, please?
Yeah, we are from Apollo Kolkata.
Apollo Kolkata.
Congratulations.
Thank you, sir.
The third team is the team 10. So both are at equal places, but I'm just
अब तो मुझे मुश्किल लग रहा है.
10.
Sir, Armed Forces Medical College, Pune.
Okay, AFM.
Congratulations.
12 marks
Thank
each. Difference is 0.5. The third place is secured by team 1 by 11.5 marks.
Stanley Medical College.
Team 1.
Stanley Medical College, Chennai.
Stanley Medical College. Congratulations.
Congratulations. Stanley College is always there.
So 1, 2, 3, 4. Fifth position is by another half marks less. That is team 2. 11 marks. Please identify yourself.
Sir, PJ Amar, Chandigarh.
Ahmed Chandigarh, team 5.
Congratulations.
6. 3.5 marks less.
Congratulations. Same to you.
5. Team 5. Team 5.
Yes, sir.
Armed Forces Medical College.
Armed Force Medical College. Great. And then I'll just read out the marks. I think team 4 has got 8.5 marks. Can you identify your college, please?
Stanley Medical College.
Stanley Medical College. Team 6 has got 8 marks.
Apollo Vishakhapatnam.
Apollo Vishakhapatnam. Team 7, 6.5 marks.
PJ
Chandigarh.
Got great. Team 9, 7.5 marks.
Sir, GMC Nagpur.
GMC Nagpur. Team 11, 8.5 marks.
So KMCH.
And team 12, 7.5 marks.
Sir, Ames Delhi.
Ames Delhi. Okay, so I'll again be very clear. We have the first team as team 8, that is GB Pant, going to Vijayawada. Then we have two teams, that is Apollo Kolkata, and other is team with the 12 marks, that is team 10. Team 10 is AFMC Pune. But there were two AFMC teams, so you are Red Dragons, right?
Yes, sir.
Yes, sir.
Red Dragons.
Red Dragons.
Dragons. Then we have on the 4th place as the Stanley Medical College. But again, you have two teams. So please tell your exact name. That is
Stanley Stars.
Stanley Star.
Stanley Stars.
Stanley Stars, correct. And another team is the PGI Chandigarh teams of the girl. And what is your team name?
Northern Lights.
Congratulations to the top 5 team. Please prepare yourself. See you soon at Vijayawada. And we'll be sending you all the details. I think they have to reach by themselves, right?
I think the ICRA will make sure that their registration is waived off, so they will be getting complimentary registration. So ICRA will confirm this, but they have to book their tickets and reach the conference venue. So all the best to all the top 5 teams and everyone else as well.
Which day is the quiz, sir?
That we have to decide and we'll let you know in a week.
Okay.
But I think your colleges would be happy to grant you leave for the full conference. They should be proud of you. Sure to give to studies.
Yeah, Gaurang.
Yes, sir.
Yeah, I think the results are very perfect actually.
Yes,
and
sir.
it was a very tough act because the way we have conducted a jumbo session of starting with each and every system, covering each and every modality with conventional CT, cardiac MR, everything. So we have judged them in a whatever best possible way. And I would say those who are not making to the finals, please don't get disheartened because it was a neck to neck competition, and the means it was like, I will put it like some sort of a higher means difficult sort of cases and quiz, so that and but other side of the story is like these are the cases which are being also commonly asked in exam. So yeah, rather than quiz, this was also equally important for you to prepare for your exams, get an experience what you know, what don't know. And another important thing what I have seen is it is like now pan India representation. You have
Exactly.
north from Delhi and Chandigarh, and south is Chennai, west
All
is
corners,
Pune,
all corners
and
of the
all
country.
4 exact corners are there. So
Yes.
little Delhi and Chandigarh are there on little higher edge. So all the best for all of you. So hopefully you'll see in Vijayawada. So as far as ICRI is concerned, we will update you regarding the registration waiver and whatever is there. So we'll communicate you very shortly.
Yes, as sir said, I think we will send an official email to CRIA telling that all these 12 teams participated, all performed well. It was a neck to neck competition, and these are the top 5 colleges. You all are winners.
Yes, and as Nitin sir has suggested, everybody should get the certificates of appreciation because it's a hard work what they have put it. And like for that, as I really, because I see so many of the residents, so many mock sessions in ICRI, but today they have answered, and absolutely salute to all the teams who have participated. Absolutely fabulous. So thank you.
Thank you. Good night, everybody.
Okay, thank you.
Good night.
Thank you, Team RX, for staying till late and helping us. Ankit bhai.
Thank you, sir. Thank you so much.
Thank you so much for keeping the score at